going live in 5, 4, 3, 2, 1. We are live now.
I will request you to please welcome everyone, and then we can start the proceedings. Thank you.
Good morning, everyone. Welcome to the second day of APWACON 2022 conference. Yesterday, we had an amazing learning experience, a lot of new concepts, a lot of new things. And today, we have a very interesting string of sessions of distal radius, CMC, DRUJ, and wrist arthritis, and of course, peri-lunate dislocations. So let's not waste much time. We'll start off the session. I request Rohan, Amit, and Deepthi to take over the session and start the talks. Rohan?
Yeah. Good morning, everyone. Thank you, Dr. Bhatt, and welcome all to the day 2. The first talk in our first session for today is by Dr. Frankie Lung. It's going to be on volar versus dorsal plating in the decision making. We'll take questions at the end of this talk. Abhijeet?
Yes, I'll play the video. Thank you. I, again, as a courtesy, request everyone to be muted. Keep your mics on mute while the sessions are on. Thank you very much.
Hi, everyone. I'm Frankie Leung from Hong Kong. Today, we'll talk about the dorsal or volar approach in the distal radius fractures. As we all know, there are 2 approaches. Most people will be very familiar with the volar approach. In fact, in my hospitals, most of the fractures are treated with a volar plating. And in fact, if we take a look at the AO classifications, almost all A-type fractures can be treated with volar approach. The B-type, the partial articular, depends on the direction of the fragment, while the C-type, actually, it's depends. Let's take a look at the type A fracture. This, we used a minimally invasive plate, and you can see it can be treated very nicely with such a small wound on the volar side, and put in such a plate if the fracture can be reduced satisfactorily, giving a very good results. While type C fractures, they are the most difficult to treat, and it depends. We can treat some of the type C fractures with a volar approach, while the C-free fractures, many a times because of the convolutions, we may have a choice of a volar or a dorsal approach. So for the C-type fractures, how do I decide? I would first of all get a CT scan, and on the sagittal view, I would take a look at the displacement of the fragment and the degree of impaction. Because if you try to do a reduction from the volar side, you have to be able to do it satisfactorily, and you have to be sure that opening a volar side, you can reduce the dorsal fragment. And of course, many times I observe the integrity of the volar cortex. Let's take a look at this fracture. And as you can see, it's an intra-articular fracture. You cannot judge whether you can treat it with a volar approach or not. But on a sagittal cut of the CT scan, you can appreciate that the impaction is very severe and is mainly tilted on the towards the dorsal side, and therefore it is very difficult to reduce this fragment from the volar side. This is actually quite impossible to do it from the, and it's actually a more direct approach to see it from the dorsal side. And afterwards, with the placement of the radial column plate, afterwards one can put a middle column plate to fix such a fracture with quite a satisfactory result at the end. Let's take a look at another fracture. This is a 32-year-old man who fell from height. And as you can see, you are not sure whether you can approach it from the volar side. But if you take a look at the CT scan, you can appreciate that the cortex is almost like intact, and the fracture involves only just the more or less escaping the articular surface barely, and is affecting the volar rim. And it could be quite difficult to expose it and see and reduce the fracture well from the volar side, and therefore it is a more logical approach to do it from the dorsal side. And afterwards, the removal of the dorsal plates, and you see a very nice restoration of the joint. So what would be my indications for the dorsal approach and plating? We actually treated most of the distal radius fractures with a volar plating. Over 95% will be treated with a volar plating, but there are some instances when I choose a dorsal approach. First is there is a dorsal middle column, or what we call the die punch, when it needs a reduction and fixation from the dorsal side. And secondly, if you really need to reconstruct a comminuted radiocarpal joint surface, then it's much easier to approach it from the dorsal side. And many a times you can also choose to apply a spanning plate fixation. The other is what we call, if you have an associated scaphoid fracture that you want to approach from dorsally, or if there are wrist ligaments tears. And sometimes if you can do a much better correction of a malunion from the dorsal approach. So this is the fragment that we want to talk about, the so-called dorsal medial fragment. You have to think about whether you can reduce such a fragment from the volar side. And in fact, to reduce the dorsal medial fragment, you have different tricks. You can still approach it from the volar side. And in case you want to do so, you have to depend on the ligamental texus. You can also try to use a Kappanji intrafocal pinning to help the reduction of this fragment. And there also has been an approach, what we call the detachment of the brachioradialis attachment. And then you rotate the shaft in order to bring the dorsal fragments into view from the volar side. I personally do not like this approach very much because it's rather involves too much dissection. In some cases, even though I put in a volar plate, I choose a limited dorsal incision to try to reduce this fragment if I can't do it from the volar side satisfactorily. Let's take a look at this fracture, and as you can see, there is a severely impacted dorsal articular surface which is actually impacted into the dorsal cortex, and therefore in order to reconstruct such a case, it is actually you need actually to expose this fragment, and therefore it would be easier to put in a dorsal plate. Let's take a look at this. And on the CT scan, one can appreciate the comminution of the dorsal rim, and there are also articular fragments which is found inside the joint. And it's important to remove the loose fragments, and therefore we choose to apply dorsal plates in this case. Although without the articular fragments, one would probably choose a volar plate in this one. So to apply a dorsal plate, it involves more dissection, preservations of the retiniculum if at all possible, and then to retract the tendons, particularly a careful dissections of the EPL around the listus tubercle. And to put in the plates, and as you can see from the C-arm view, that you can achieve a very good reductions from a dorsal incision. And afterwards, we put in the fragment specific. These are what we call the variable angle plates. And with such a dissections, afterwards, we can have a very good reduction of the joint surface and all together. And as you can see, the tendons are all respected and well preserved. Some other cases when we choose a dorsal approach, when there are associated ligamentous injury as seen in this one. And as you can see, there's also a scapholunate kind of instability. And that's why the surgeon choose a dorsal approach. This is a case from Professor Jupiter. Let's take a look at some other cases we've done from a dorsal approach. This is a 55-year-old man who fell from height. And as you can see on the CT scan as well, is a very comminuted distal radius fractures. And already there are some signs of a significant radius shortening. And the ulna shaft is also fractured as well. So what do? We actually, in the first stage, we aim to do a spanning dorsal plate because of the comminution of the fracture and the articular surface. And in order to do so, first we reduce the DRUJ satisfactorily, pin it with a K-wire. We still find the ulnar plate, the ulnar side to be slightly longer. So we trim the fracture a little bit. We did a slight ulnar shortening and then put in a spanning dorsal plate. And as you can see, at 6 weeks' time, the fracture has united. It still looks a little bit ulnar plus, but it's already quite satisfactorily healed. And that's why we removed the dorsal plate at this juncture at 6. Normally, we do it at 6 to 8 weeks' time, depending on the healing of the fracture. And this is the end results at 9 months. And as you can see, the distal radial ulnar joint is in a satisfactory alignment. There is still a slight ulnar plus, but the patient's outcome is actually very good. There's healing of all the fractures, and the range of motion is also very good. Let's take a look at another case, which is a 48-year-old, again, high energy injury. All these, if you take a look at these kind of fractures, then you expect to use a dorsal approach because the fracture is really comminuted. And as you can see on the CT scan, the fracture is not well reduced even with a spanning X-fix. The surgeon did try to fix the scaphoid as well. And as you can see, is still not well fixed. This patient later developed a carpal tunnel syndrome. And that's why we have to redo the whole fixation and also release his carpal tunnel as well. So again, what we did is we did a dorsal spanning plate. I also add a volar plate as well to help with the reduction of some of the comminuted fragments. I fixed the scaphoid in a much better situations. And then the spanning plate was removed at 1 month's time, because now this time I don't have to wait for the complete healing of the fracture because there is also a volar plate which helps to support the fracture. This one has quite a stiff wrist initially, but at 6 weeks' time, after a vigorous kind of rehabilitations, he did have a satisfactory outcome. So I would like to summarize my talk. The choice between a dorsal and volar approach can be quite easy most of the time. I treat most of my fractures with a volar approach, but on the CT scan, I would try to read the sagittal view, appreciate the degree of comminution where the fragments are, and if there is intact volar cortex when you open up and you cannot approach the dorsal side. So you have to make a judgment how to reduce the dorsal fragments from a volar. If not, then you better choose a dorsal approach. So the more comminuted joint surface fracture, then we tend to use a dorsal approach because you can actually see it much better. And if you choose to use a dorsal spanning plate, again, then a dorsal approach should be used. And in case of associated scaphoid and ligamentous injury, then a dorsal approach should be used.
All right. Thank you, Dr. Frankie. This was a great talk and a great eye-opener. While we wait to get questions from the online chat box, Dr. Bhatt, can I go ahead with a question for him?
Yeah, please. Yeah.
Two questions rather. One would be, suppose there's a radial styloid fragment, so a dorsal-radial or just a radial styloid fragment. Does the dorsal approach help, or it's just a plain radial or volar approach? Is he there?
I'm not sure whether he's logged in.
Okay, fine.
You can check with any of the other senior faculty if they want to answer.
Dr. Bhatt, would you like to take this?
Rohan, just repeat the question. I was just going through the box.
Yeah. All right. So suppose we have a dorsal-radial fragment or a radial styloid fragment. Does the dorsal approach help, or we go via a direct radial approach?
I think basically your closed reduction initially would be the indicator for that, as in when you you see how the fragments align when you give the traction and see the closed reduction status, and then see how these fragments are moving with relation to each other. And that is the time probably you need to take your decision whether you require an additional dorsal approach straight away, or you would want to hold them on from the volar side. And there are many ways to do it. So if you think that that particular fragment can be held from the volar side, but you require a little more assistance, you might go for a mini incision from the dorsal side. You can use joysticks. As mentioned, it could be a Kapanjis. It could be, I sometimes use just a threaded K-wire to just push it, hold it there, and then go from the volar side. So there are many ways, but my decision making happens basically when we start the case, we just check in the C-arm, do a closed reduction and see how the fragments are moving against each other. So if there is any kind of a depressed element which doesn't come out, or the fragment doesn't move, it just stays there, then a more direct approach will always be advisable.
Okay, thank you. Amit, do you have any questions?
No, I don't.
We don't have questions on the YouTube chat box as yet. I've not yet received any. If we get it, then maybe a little later I'll ask.
Shall we play Dr. Ku's talk before we move on to Greg Bain's talk? Because
Abhijeet, I've just checked with Dr. Brain and he's okay with that. Yeah.
All right, great.
All right.
That's okay. Thank you.
Thank you.
Amit?
Yeah. So in the session, next talk is about rim fracture techniques, rim fracture techniques of fixation by Jeffrey Cook.
Thank you. The organizing committee allowed me to present our work in treating special conditions in distal radius fractures. Studies have shown that lunate facet is the keystone for both radiocarpal and distal radial joint, and this is the attachment of the important short radiolunate ligament which stabilizes the volar aspect of wrist and the lunate bone. The stabilization of this fragment can lead to volar carpal subluxations. When volar carpal subluxation occurs, there will be decrease in wrist range of motions, loss of forearm supinations, and decrease in hand functions. In the long run, painful post-traumatic arthrosis will be the result. Why the volar lunate facet is difficult to stabilize it because of its small size, and it is situated distal to the watershed line. Unlike those roller rim plate that is specially designed for this purpose, most of the roller plates in the market have minimal effect capture length more than 10 mm that make it difficult to support the small fragment. Also, there is risk of flexor tendon irritations and intra-articular screw penetrations if we attempt to place the plate distal to the watershed line. Other complications such as articular surface concavity, loss of fixations, CRPS are common and range from 11 to 41%. There are many fixation techniques that has been mentioned in the literature, including the external fixator, KY and Y loops. Bush use external fixture as a supplementary support to provide ligamentous access to reduce the dorsal lunate facet and set the roller plate to directly reduce the roller fragment. Other method that Moore described is to use the KY holding the roller rim fragment in positions either with or without roller plate. Chin and Jupiter has used KY and metal wire loop to reduce and hold the roller facet fragment. Brandis has described his modification for the above methods. He combined the two together. First, use the two KYs holding roller rim fragment and pass the KY through the dorsal skin for easy KY removal later. Then, making use of the additional steel wire or suture pass through the roller joint capsule, holding the fragment and then tied onto the plate. This method has been used in my early cases. This patient has dislocated fracture with lower carpus dislocation after road traffic accident. I have performed arthroscopic assist fracture reductions and fixations. I used two KYs holding the roller rim fragment and suture pass through the joint capsule to stabilize the construct. Additional SL and TFCC injury was treated with SL pinning and TFCC repair respectively. Distal radius KY was removed at 3 weeks, starting gentle wrist mobilizations exercise and SL pinning removed at 6 weeks to continue physiotherapy with strengthening exercise at 8 weeks. This is a result of 4 years after operations and patient gained excellent functional results. The advantage of this method is expensive, but needs the bone not osteoporotic and no metaphyseal combinations. Now we have roller rim hook plate holding the roller rim fragment in place without shifting the plate beyond the watershed line. Low profile design can avoid flexor tendon irritations and safer screw trajectory helps to minimize the intraarticular screw operations. They can be used either separately incorporated in the distal radius roller plate or part of the fragment specific plate system. With the new plate becomes available, our unit has set up the following treatment algorithm since 2018. CT scan is useful to assess the fracture characteristics and helpful in decision making and planning. We consider using the roller rim hook plate when the lunate facet fragment length less than 10 mm. One common pitfall that often encountered is the dorsal tilting of this roller lunate facet fragment, as it would result in joint incongruity, limited range of motions, and early orthosis. So I would prefer to use wrist arthroscopy to assist the fracture reductions. One reduction technique that I find it useful is to reduce the dorsal tilted roller rim fragment is to pass a single suture over the roller joint capsule just distal to the roller rim fragment as rings. Gently pulling the sutures will reduce the dorsally tilted fragment back to the normal position, and the suture can be tied on the plate to further stabilize the construct. Dorsal articular fragment can be lifted up and reduced by using KY as thoracic under arthroscopic guidance. From October 2018 to November 2020, we have 13 visits in 12 patients recruited in our studies. Mean follow-up time is 14.5 months. Male to female ratio is 1.1, and half of them injured the dominant hand. 5 males who are less than 45 years old suffered from high-energy trauma. There are 6 B3, 3 C2, and 4 C3 in our series based on AO classifications. Average roller rim length and lunate facet substance are 5.76 and 1.9 mm respectively, and there are 3 associated SL injuries that are treated accordingly. Unless the patient has SL or TFCC injury repaired, we start our usual early active mobilization rehabilitation program. After the operations, we have performed CT scans and compared the radiological parameters with an injured normal side. All have restorations of radiological parameters that are comparable to normal side except the ulnar variance. For the functional outcomes, we have compared the range of motion with normal side. All have statistically comparable range of motions except wrist fractions. And grip strength have restored to 94.2% of normal side. Mean quick test score was 6.72 out of 100. 5 excellent, 1 good, 7 satisfactory was found in our group when assessed by modified male risk scores with mean score of 18.4, and all patients did not have complications. From our statistical analysis, demographic parameters did not affect the radiological and range of motions. Also, if fracture being reduced probably, fracture characteristics such as severity, roller rim fragment length, and substance did not affect the found count. However, grip strength was affected by the fracture severity and presence of SL injuries, and fracture severity has negative impact on modified male risk scores rating and quick test score. In conclusions, for those roller rim fragment length less than 10 mm, special attention is needed. Fixation stability can be improved with specially designed rolling hook plate that can allow early mobilizations and achieve reasonably good results.
Can we continue on the second talk simultaneously? Arthroscopic assisted fixation current evidences.
Yes. I think, and then we can take the questions together.
Yeah.
Thank you.
Thank you, the organizing committee, for inviting me to share my experience in using arthroscopy in treatment for distal radius fractures. Much interest has been put into the effect of radiological parameters on the functional outcome. Now we all know that radial shortening 2 mm articular depth of an intraarticular gap are a few factors that will affect the functional outcome. It is easy to understand why the radial shortening affects the outcome and it creates positive ulnar variance, causing ulnar impingement syndrome, and it is a source of pain and disability. An articular step-up increased articular surface irregularity, leads to cartilage damage and early degenerations. And Gabby's paper shows the importance of articular gapping. He has performed wrist arthroscopy in 20 distal radius fracture patients at the time of implant removal. Just like the findings in my case, he found there is a fibrous tissue formation from previous fracture gap onto the surrounding joint capsule. These fibrous scars limit the range of motions and therefore affect the functional outcome. So precise reductions of articular surface help to decrease the chance of scar formation inside the joint. Therefore, arthroscopy is a suitable method as it can provide magnified view to assess the articular status and reduce the fragment. Terribly pioneer in the application of wrist arthroscopy on distal radius fracture treatment, and subsequent research shows promising results. Although many will say that X-ray is already good enough, but no one has used wrist arthroscopy to assess the articular fragment reductions after fluoroscopy, and find that over half of them still have articular gap and around 20% has articular step of more than 1 meters. There's room for improvement and wrist arthroscopy can help. Right now, my indications for using arthroscopy are unstable intraarticular distal radius fractures and suspected soft tissue injuries such as TFCC, SL, and LT intraosseous ligament tear. Preparation is important. CT scan of the injured wrist helps us to analyze the fracture patterns, and contralateral X-ray helps us to appreciate what is the normal risk for the patients. Timing of surgery is usually around 1 week to avoid iatrogenic compartment syndromes. You can start earlier if you use right arthroscopic techniques. I will use variable angled molar distal radius locking plate because it provides stable construct and allows precise screw placement onto the fracture fragment. The plate designed to have a window allows me to create an access point for you to manipulate the articular fragment after plate applications. Fracture reductions can be divided into different steps. First, the volar metaphyseal and articular fragments is reduced. Preferably start from the outline side first, as the bone contact is thicker over that area, followed by the radial side. Then the volar distal radius locking plate was temporarily fixed onto the radius, act as the buttress for the reduced volar fragments. KY anchor the volar fragments onto the plate. Our method helps to restore the overall radiological alignments because normal positioned volar fragments can be used as a reference point for the reductions of the remaining dorsal fragments. We use the standard setup for wrist arthroscopy, applying 12 pounds tractions using traction tower. For the wing portal, I prefer to use 6R portal because it allows the scope to rest upon the ulnar head, giving you a steady wheel, and would not depress the dorsal fragment as in 3-4 portal. Often there's lots of blood clot inside the wrist joints. You can use 10mm syringe filled with saline, insert the side after the scope, and perform aspirations by arthroscopic shaver. The suction force will draw the saline with the blood clot out of the joint. Then we use the probe and shaver to dislodge the blood clot inside the fracture gap. After the fragment is free to move, we can start fracture reductions under arthroscopic guidance. The use of different techniques depends on the fracture pattern and configurations. If the fracture is displaced, use the probe to hook the fragment or use the additional KY from the dorsal as joystick from fragment manipulations. For aerated fragments, release the traction helps the fragment reductions by field aerator. Free osteochondral fragment needs to create an cortical opening through the window of the roller plate, then use the banded 2 mm KY to push back the fragment in the positions inside the intraluminary canal. Then use your thumb to compress the reduced fragment and drive in the supporting KY. And our study in 24 patients with AO type C distal fractures shows this method can help our physician group performs better in terms of articular gap stepping and gapping reductions, restorations of radiological parameters, range of motions, grip strength, and motor risk scores. AOS has recently published a guideline that they showed there is moderate evidence not supporting the use of arthroscopy in these radius fractures. But be mindful that the conclusions is made only based on 3 studies. The first one has the first articular restorations in articular capping and stepping in a well under fluoroscopy. The second paper does not use the arthroscopy to assist the reductions, they just wash out the blood clot inside. The last paper have shown better restorations of the range of motions and functional scores in arthroscopic group but not mentioned in the guideline. So a good quality recommendation is not available at this moment. Then we look at the latest evidence to help our decisions. Edwards' paper showed arthroscopy often discover larger step-up and gap than plain X-ray or C-armed, and they often underestimate the amount of articular gap compared with arthroscopy, and C-arm often unable to detect 2 mm articular step-off. SARP looked into 21 studies within 10 years. Most of the papers show arthroscopy is helpful for intra-articular fragment reductions and contribute to the detection and treatment of concomitant intra-articular soft tissue injuries. But whether arthroscopy can give beneficial effects on patients' functional outcome is still controversial. This year, latest meta-analysis showed similar results in reductions of articular step-up but not gapping. Sepp's paper, arthroscopy can increase the detection rate of intra-articular soft tissue injuries, but they also noticed no effect on functional outcomes and longer operation time in arthroscopic groups. So, in conclusion, it demonstrated that this arthroscopy can be an important adjunct in distal radius fractures fragment management, and it provides excellent visualizations of articular surface for anatomical restorations and allowed evaluations and treatment of intra-articular soft tissue injuries simultaneously. But long-term prospective follow-up studies need to support its use. Hong Kong SSH Annual Congress on 25th and 26th March next year. Main theme is technological advancement in hand surgery. We invite all of you to come and join the webinar from Hong Kong.
Yes, excellent talk, sir. For the first talk, can the rim plates can be useful for the volar lunate fragments?
Yes, I think this is very useful to approach the volar rim fragment through the roller approach, and also apply the plate to support the volar rim fragment, because the special design on the plate helps you to stabilize the small fragment that is not usually possible to use the standard plate, because from my observations and measurements on the standard roller plate, most of the plate in the market for the standard design cannot help to stabilize the rim fragment. So I think this specially designed for rim plate helps us to stabilize this fragment. Yes.
One question from the chat box, that what is the cost and need for later implant removal?
Yes, for our cases, in my studies, that only one cases want to have an implant removal, but not due to the symptoms or implant irritations on the extensor tendon or median nerve. We just want to have a plate removal. Others, we don't have implant removal for our cases. I think it is based on due to the low profile design of the plate over the distal part of the plate. So there's less irritations onto the flexor tendon and also the median nerve.
Yeah. One more question. Mostly this volar lunate fragment and the dorsal part is simultaneously there. So is it change your some approach or you fix it by both approaches?
Yes, so that's why I use the wrist arthroscopy. So the wrist arthroscopy helps you to look into the dorsal parts, so that you can use either using hook to hook it back to the normal positions, or you can make a small incisions over the dorsal side using KY to help you insert into the fragment. Use it as a joystick to put it back into non-reduced positions. So this is the usual way that I do the I dealt with the dorsal lunate fragment.
One question from chat box. Do you routinely close pronator quadratus over the plate?
Yes, I always prepare the PQ pronator quadratus into the positions, because it helps protect the flexor tendon as well.
Okay, Rohan, do you have any other question?
Okay, Dr. Deepthi had asked on the chat box, how often do you use suture augmentation along with your rim plates?
Actually, almost 100% of the cases I use this method, because I think sometimes, especially when I use the old method that the Francis has taught us, because it's helpful to reduce the fragment, because you can imagine the fragment is very small. And if you put the suture over the molar joint capsule just distal to the fragment, it actually can help you to reduce the fragment much better. So almost all the cases I use the suture augmentation method.
Okay. There was a question which came a little late for the first speaker. Let me ask it here. The dorsal spanning plate that was shown in the case for a comminuted distal end radius, was that a recon plate or was that a locking compression plate? And what was the size? Was it 2.7 or 3.5? Dr. Jeffrey, you can take this question and just share your thoughts for dorsal spanning plates.
For my limited experience, I seldom use this joint spanning technique, because I find my technique on using the wrist arthroscopy is actually is good enough to reduce all the fragments inside. And from just in case if I use the spanning plate, is the standard 3.5 plate.
All right.
Because in Hong Kong we don't have any specialized joint spanning plate in the market in Hong Kong.
Okay, and then how early or how late do you end up removing the dorsal spanning plate?
The dorsal spanning plate, okay, it is around 6 weeks but it depends on whether the fracture is healed or not. We need to have a CT scan before we decide whether it is the time to remove the joint spanning plate.
Okay, thank you so much. Dr. Bhatt, we don't see any further questions on the chat box as well as the YouTube box.
Yeah. Mr. Rishi, can you make Parag Lad as a co-host? Because he'll have to play Dr. Bain's talk through his laptop. There were some issues to download it. Rishi? Rishi from Ortho TV?
Rishi?
I think I am able to share the screen. I will just start.
Yeah, great.
Can you see my screen?
Yes, we can.
Yes, Parag.
Yeah, can you see the presentation?
Yes. Yeah, please go ahead.
This is Greg Bain speaking. Thank you for putting this talk together up onto the screen for me. This talk is on sleeper lesions. If you can now just advance through to the video, which is the third slide. Thank you. It's got a voiceover with it.
Okay. Is this the third video?
So we recently performed a set of fracture mapping, particularly on volar rim fractures, which has been an area of interest for us for some time. And what we can see here is that the volar rim is always at the same distance from the lunate, which demonstrates that the short radiolunate ligament remains intact in all of these cases. If it's a small fracture fragment, then there's likely to be a greater degree of subluxation of the carpus than if there's a larger fragment. What we refer to as the pronation angle, this is the angle of malreduction of the volar fragment here. So we know that if there's a smaller fracture fragment, that there's a greater degree of pronation as it rotates around the triangular. The lunate facet gives some support, although it's fractured for the lunate, but the scaphoid looks even more unstable. So we think the short radiolunate ligament remains attached to this fracture fragment, but the radioscaphocapitate ligament is clearly disrupted to allow the scaphoid to subluxate this much. Instability of the lunate and the scaphoid. So there must be an occult ligament injury. So we recently performed.
Okay, I might just speak over it. I think we just stopped that video there. So the important thing is with these sleeper lesions that they are something that we don't identify. Maybe just turn that video on pause.
Pause the video, please.
So the sleeper lesions are important because they're not a common lesion, but the patients may actually present.
So in this example here, we can see the set fracture. We can see how it's rotated, but we can also see how the scaphoid is also unstable. And if we look at the image on the right,
and pause the video, Parag.
It gives some support, although it's fractured for the lunate, but the scaphoid looks even more unstable. The short radiolunate ligament remains attached to this fracture fragment, but the radioscaphocapitate ligament is clearly disrupted to allow the scaphoid to subluxate this much. So what we've got is a lunate facet fracture, but instability of the lunate and the scaphoid. So there must be.
Okay, there's obviously a bit of a technical problem with that video. If I can just make a few comments. So the sleeper lesions, firstly, they're an important lesion, and it basically means there's a soft tissue injury associated often with a fracture. So these patients may have a swollen wrist, may have dislocated the joint, and we may just see there's little avulsion fracture fragments as part of the associated injury. I think we need to be mindful that these injuries can occur and that we should try and predict them based on the mechanism of injury, the severity of the soft tissue swelling, and the type of changes that we see when we review the imaging. We should also consider performing an examination under anaesthetic, arthroscopy to assess the associated ligaments because we can actually see them and probe them, and then we need to stabilise the fractures and maybe consider putting suture anchors in to stabilise the associated soft tissue injuries. I think we're best not to play that video anymore. I think there's obviously going to be some difficulties with that, but maybe it'd be appropriate to take any questions from those who are listening to see if there's any comments or concern. I think we stop that video now.
But you can stop the video. Yeah, Dr. Bain will speak without that. Yeah.
I don't know if you could hear me just speaking over that just now.
Yeah, it's all clear, Greg. Please go ahead.
Do you want me to continue, or did you just hear what I said then?
You could continue.
Okay, so the sleeper lesions are an important group. they're a fracture dislocation typically, where we identify the fracture on the X-rays or CTs, but there's an associated soft tissue injury that we need to be aware of and predict them based on the fracture pattern with small avulsion fractures and associated subluxations. And this should lead us to be concerned that there may be this type of problem. And arthroscopy is a valuable tool to be able to identify these lesions more accurately. So I apologise that there's been some technical issues with the AV. Are there any questions, Abhijeet?
Any questions for Dr. Greg Bain? So, Greg, I have a quick question for you.
Yes.
Like yesterday, we really enjoyed your talk on the scaphoids as well. And now from your work, we are kind of getting a trend that the ligamentous or the capsular attachments of the bones have, or they result in a predictable fracture pattern. So does that kind of apply to, perhaps all the fracture dislocations or the fractures around the wrist? Would you think so?
No, that's a great question. So at the end of the day, the stability of the joint is provided by the ligaments. So to create a dislocation, there must be an associated ligament type injury. So it's not just a fracture. So in fact, if there's a dislocation with a fracture, then in fact, it's almost like an avulsion fracture would be the typical scenario. So you're right. So I think it's really important that we really step up our understanding of how we assess these injuries and the importance of the associated ligament injuries. Thank you, Abhijeet. That's the perfect question.
Great. Thank you so much. That's wonderful. Thanks for joining in. Are there any questions for Dr. Greg Bain from anyone of us?
Abhijeet, Dr. Anirban has asked on the chat box, does the stabilization of the volar lunate facet stabilize the scaphoid instability?
Not completely. So if you stabilize that lunate facet fracture, then you stabilize the lunate. But in fact, the scaphoid is stabilized by the long radiolunate ligament and also by the radioscaphocapitate ligament. So we have seen a few examples where we thought that the fracture was stabilized, and it was, but yet there was still some persistent instability. And that may not present initially. It may be at review or 2 or 3 weeks when that presents. So in those cases, it's really this concept of we've provided some stability, but we haven't provided stability of the associated ligament injuries. Another good question.
Dr. Bain, between doing an intraoperative arthroscopy versus getting a preoperative MRI imaging for these soft tissue lesions, what would be your choice? So
what we're tending to do is those patients where we predict there's going to be big problems, we do the CT and the MRI. So that way that we understand it. And in the elbow as well, we've found that to be very useful. I think arthroscopy is also useful, an examination and under anaesthetic to see whether if you put the wrist into, see if there will be an ulnar translocation or volar translocation, because sometimes you'll unmask this instability to the point where the wrist will literally dislocate. But previously, we weren't thinking like that. I think the important thing is to identify that these associated injuries and really start to think of how these ligament injuries can be part of the picture.
Thank you.
Rohan, there's one more question.
Yeah, I just saw that. What would be the approach to simultaneously address the scaphoid instability along with the volar lunate?
Right, so if we would have already made a volar approach to the wrist and we would have stabilized the lunate facet, similar to the previous talks. The previous talks were perfect of showing how to stabilize those volar fractures. But then I think that we should consider and explore while we're there whether there is an associated volar ligament injury over the scaphoid facet, but also the distal radioulnar joint can be, it's not uncommon with complex wrist injuries to see a distal radioulnar joint stability. So if you've made a volar approach to the distal radius, you can put some suture anchors into the soft tissues over the scaphoid facet, or you can go ahead and do stabilization of the distal radioulnar joint. and that can be done arthroscopically or as an open technique.
Right. Thank you, Dr. Bain.
Thank you very much. Thank you.
Dr. Bhatt, no more questions on the chat box.
Yeah, thanks, Rohan and Amit. I think we can move on to the session with Vikas and Chetan coming in. Vikas?
Yeah, hey.
Yeah, hi.
Hey.
Could you please announce the...
Yeah. Is Chetan joining in? So Anil, first we'll start with your first talk about trapezium. Whether we hello.
Yeah, Vikas, you're audible. Yeah, go on.
Yeah. Okay. Can you start with the first talk about trapezium fracture? Is it like a reduction? And I think this is your first talk. Just a second.
The first one is my talk on CMC. Yeah.
CMC joint. Yeah. Can we start with the talk?
Yeah, Abhijeet will play the video.
Hello, everyone. The topic is congruency crucial in CMC joint? And well, as we evolved, the bipedalism and the club wielding more towards computers and software, this demand for less constrained joint became more and more. Dexterity for precision was what was required, and the price we paid was arthritis in a not so typical weight-bearing joint. And if you look at the anatomy itself, the articulation is by reciprocal reception. And it's a functional paradox of mobility and stability in these joint. Because it's a concave-convex saddle type of design, it functions almost like a pivot joint here. And only 50% of the population show congruency and is more flatter in women. And the maximum contact happens in opposition, which is still about just 53%. If you look at adduction and abduction, it's about 25% of contact which happens. So the movements which happen in all these usually is more of a slide and a roll kind of a combinations. In flexion and extension, the extension couples with adduction, and in flexion, it couples with abduction. So this is what happens during the flexion and abduction, flexion and abduction and extension and adduction combinations. When it's in palmar abduction and adduction, again the roll and slide comes into picture, but it's also the action of the muscles is associated with muscles. The abductor pollicis is longest in the adductor pollicis, which keeps this kind of a movement which is happening. And the ultimate kinematic expression is the opposition, where there's a maximum contact. And in the opposition, it's considered as a close packed position of the CMC joint itself. About half surface area within the joint makes articular contact, which I said earlier was just about 53% here. And probably this predisposes the joint to potentially damaging pressures because it's a close packed position. And when it comes to grasp and pinch, ulnar translation, flexion and abduction happens in a grasp. And when you talk of key pinch, there is a metacarpal volar translation which happens, the internal rotation which happens, and flexion of the trapezial surfaces happens in the key pinch. So these are the joint mechanics which causes probably a little more damage to these joints as the joint works against these forces. So why does this joint get abused? Well, there could be other factors like generalized ligament laxity, the postmenopausal influence, the skeletal architecture which we have seen all this time, and the intricate kinematics, which is the coupling and uncoupling of these forces, and of course the role of soft tissues and the joint reaction forces at the base of the thumb. So the articular incongruity or the congruity per se is the disparate radii of curvature, which are congruent on extremes of motion itself. And as I said, maximum in opposition. Well, the secret lies in becoming congruent when the joint wants to. And that's probably what we need to understand. However, it still remains shy of full congruency, lest it loses its dexterity and mobility. At the end of the day, it's a sum of all the parts when it starts moving, the joint, the ligaments, and the muscle tissues, which all act in synchronous. Well, you can put it as probably this joint is an incongruously congruent joint, and that is why it's got its mobility and its dexterity. And if you look at this patient who came to us, completely damaged joint, and this is a deformity seen, and patient absolutely had no complaints. Patient actually came for some other reason. And when we asked specifically, there was full range of motion. And this patient, she was doing everything, all her activities, and there was actually not her major complaint at all. And this is what is the secret about this congruency. When I tried to put the joint, which I thought was congruent as a surgeon, she started getting pain. She was telling me that when I tried to do this passive movement, she actually had pain. So this is what it is. Is the congruency required or crucial? Well, it is required. How much is the question? And congruency was compromised for mobility and dexterity. Well, this compromise is further affected by genetic, metabolic, and occasional factors. At what point of time the joint becomes symptomatic for the patient is really difficult to judge. And nature had a balance for this. And well, as surgeons, we're still trying to find it. Thank you so much for your attention.
Thank you, Anil. Nice talk. So any questions? Because I can't see any question in the chat box. Any questions from the panel? Anil, is there a difference between if there's an acute incongruency or a chronic congruency? Like, would there be a change in the symptoms? Like,
yeah, definitely that matters, especially when we talk of acute situations. It could be Bennett's, it could be Rolando's, it could be trapezium fracture itself. If you talk that way, in a long term, if you take that effect, definitely it will lead to a much more painful kind of a thing. But if we take off a chronic arthritis, which patients come in usually for us over the years, where a joint is now the joint is adapted to that incongruency. That's what is trying to tell, that at what point of time the congruency, which goes on to become, an incongruent joint, and when the treatment is required, is very, very important. I mean, we shouldn't be looking just at the X-ray for that. So if you look at a patient, young patient with a trapezium fracture or a Bennett's or a Rolando's, I think the decision making becomes very easy compared to a lady who comes in after a long time and where the joint is adapted so well, right? Especially we see high patients, we see that very often compared to the Western world. And that is where our decision making takes so many different dimensions, whether we really have to do something or not. Very crucial for a surgeon to understand that. Yeah.
thank you, Anil. Now we can invite next talk by Dr. Chan. Trapeziectomy alone versus additional suspension plasty. What is the current evidence?
Good morning. Yeah. Colleagues in India, the colleagues in online. I'm Dr. P.T. Chan from Hong Kong. Today, my topic will be on the current evidence of trapeziectomy alone versus additional suspendoplasty. I have no conflict of interest to disclose. So this will be the content of my talk. I will talk about some of the history, trapeziectomy versus LRTI, trapeziectomy versus tight lobe suspendoplasty, and some survey on current practice. During the medical literature review, I must resonate the late Pomansky commentary. He said that on the occasion of this reviewing medical literature process, it becomes circular and brings the reader nearly back to the original starting point. What goes around comes around. That's why I said so. Because the first trapeziectomy was described in 1949 by Harvard Griffiths. He reported 18 trapeziectomy in 15 patients and 88% were good result. And 25 years later, he wrote another report with more than 100 cases. The merit of that report is he said his own CMC joint arthritis has been treated by trapeziectomy alone, and he is still able to perform operation. And 10 years later, Dr. Murray also reported his cases of trapeziectomy But in his report, there's about 15 of patients complaining of weakness of grip. Although there's weakness, the power actually about 3/4 of the normal, and the functionally, the patient was satisfied. And because of this subjective weakness, their surgeons would develop other type of operation in order to tackle the weakness. And Dr. Ferguson in 1970 described the interpositional arthroplasty by tendon ball, and he performed 12 operations in 10 patients and all with good result. And Dr. Burton also reported his cases of suspendoplasty with 25 thumbs in 24 patients, 92% excellent result. So there are so many different methods. And Dr. Davis first reported first randomized trial with a suspendoplasty versus trapeziectomy versus trapeziectomy with PL tendon interposition, and also trapeziectomy with LRTI. And his report comment that the outcome at 1 year is quite similar for 3 types of different operation. And the satisfactory rate is more than 80%. And the complication rate for types of operation is also similar. And then here come the more powerful Cohen library report, which included 11 randomized controls trial with 670 participants with 7 types of different type of operation. And the final conclusion is there's no procedure demonstrate any superiority over another type in terms of pain, function, quality of life, patient scorable assessment, and adverse event. That means all these type of different operation have quite similar outcome. And the trapeziectomy with LRTI may not provide any additional benefit, result in more adverse event over trapeziectomy alone. That means the suspension did not add any benefit. And also there comes very good long-term outcome because the long-term follow-up more than 15 or 17 years is for trapeziectomy alone is very good. So there's also huge reports of that there's no additional benefit of trapeziectomy with LRTI over the trapeziectomy alone. How about tightrope suspension? And Dr. Mohan reported 56 operation. About half of them is trapeziectomy with tightrope suspension. 26 is trapeziectomy alone, and the average follow-up is around 1 year. And there's no difference in functional outcome. But however, the complication rate in the literature in tightrope, there are on and off case report of delayed atraumatic fracture of the second metacarpal, and also some cases of EPL ruptures. So we have seen a very convincing evidence that trapeziectomy alone works well. How about the surgeon's preference? And there are few reports of surgeon preference, 2 in the American side and 1 in the Europe side. Surprisingly, even in the latest 5 years, most surgeons prefer trapeziectomy with LRTI over trapeziectomy alone. That means more surgeons are performing trapeziectomy with LRTI, despite the evidence that trapeziectomy alone works well. So another report of the survey on the in the American College, American Society of Hand Surgeons, they sample the Medicare's fee of service beneficiary for the CMC joint arthritis. And they found there's increasing trend of using trapeziectomy with LRTI. So there are some factors affecting the surgeon's preference over the best evidence. This may due to their experience, their training, or along with the special type of procedures, the consumer demand, or sometimes maybe higher physician's satisfaction or reimbursement rate. So in summary, there's good evidence that trapeziectomy alone works well. Many surgeons are not practicing according to the best evidence. Maybe it's time for a change. Thank you.
Thank you, Dr. Chen. Nice talk. Really, a lot of evidence pointing towards the trapeziectomy alone. I'll invite any questions from the panel.
I have a quick question for PT. PT, are you here?
Yeah. There is a question in the chat box.
Yep.
Dr. Jeff Ecker has a question.
Yeah, Dr. Jeff Ecker has a question about hemi-trapeziectomy, like distal trapezium versus total trapeziectomy. What is the evidence about it?
PT? I'm not sure if he's logged in. I think he was here in the morning, but.
Another question from the previous speaker, Dr. Anil from Vinit. What about the person in early 30s, CNC subluxation? How do you go about it? Can you answer, Dr. Anil?
Yeah, I just answered in the chat box, but
yeah, but I want for the benefit of the viewers.
So basically, young patients, we do sometimes see this. I would take the opposite side X-ray. That's the first thing I would like to do and check the anatomy of it. And second, of course, rule out any generalized ligament laxity in the patient and see what do they demand and what is their occupation, and then take a decision as to whether any intervention is required at that point of time. Absolutely asymptomatic, that would be the usual presentation, but you would see that subluxation sometimes. Patients sometimes come with, showing the deformity on one side. If it's not, there is some pain starting off, and again, based on their occupation and functional demands, maybe an orthosis would help initially. I think I would go really slow on these patients, young patients, and then take a decision as and when it becomes symptomatic.
So if you have no questions, can we move to next talk from Dr. Ida Ball? Arthroscopy in early stages of first CMC joint osteoarthritis.
Jeff, yeah, I think Jeff Ecker has a question. Jeff, but I think PT is not logged in, Jeff.
No, it doesn't matter. PT is not there. Thank you very much. He's not online. Thank you.
And I think there's a talk on hemitrapeziectomy by Jutin Shi. We can perhaps hear from him.
Thank you.
Thank you.
Hello everybody, CMC1 osteoarthritis and arthroscopic treatment is my topic. I have no conflict of interest. CMC1 osteoarthritis associated with hypermobility and idiopathic joint subluxation in dorsal-radial direction. Here we have the anatomy, we have the supporting tendons and the ligaments from the dorsal and the palmar view, and here we see the most important ligaments, the AOL, SL, peak ligament and DRL, what are the most important for stabilize the saddle joint. There are different treatment options and according to stages, but also according to patients' needs, wishes, profession, and so on. This is the case, for example, a 17 years old lady, she's coming with that osteoarthritis, and she showed me and said the doctor sent her. She has no pain, so I think there's no need to do a treatment at this age. And here's the function where she's very happy with. So here we have a very busy chart, but we see there are a lot of arthroscopic treatments, and this is what I want to talk about. First one is the instability. It's not stage 1, it's stage 0 if you want. So we do arthroscopy, synovectomy, shrinkage, and maybe a corrective osteotomy at the meanwhile. At the beginning we also added this Wilson osteotomy at the end, only in arthritic changes. So what is the aim? Painful instability, reduce pain, increase function, and delay of osteoarthritis maybe. We do first the arthroscopy with the standard portals. Here you can see them as well, like here. And you can see what we need to take care of the radial artery and the nerves. They're all running around here. So I do longitudinal incisions. Here we see the view, instability, we check the ligaments, they're very lax, even in traction, and then we do a synovectomy, and afterwards we go for the shrinkage. We need to be careful with the heat and to put enough water supply to don't burn the cartilage. 6 weeks post-op with splint orthosis for stabilizing. And this is for checking the stability, and we see that it's really different. And we see it also in this X-rays, and the range of motion, Krebs-Kapanchi works very, very well. So if there's still a little bit further on, arthroscopy, arthrodebridement, and we can do some interposition, autologous tissue or tendon or fat, or pyrocarbon. So treatment options for me, what I want to propose here is autologous fat grafting. I was looking about this patients. The same portals, same approach, and here we have a partial grade 4 cartilage lesions. As we can see here in this video, some areas are very nicely and other ones are still bare bone. Simultaneously we can harvest the fat and sedimented the fat, and at the end we can put this in the joint. After debridement, as we can see here, 2 weeks splint, and this is 3 months post-op. So we see there is a lot of pain reduced, especially over the long term, quick dash as well over the long term, and strength is still increasing after up to 2 years. Range of motion is always more or less the same, as well as the Kapanchi score. Satisfaction is getting higher for the long term as well. At the beginning I put a key wire for transfixation. I don't do it anymore, and there were some complications. The trigger finger and one Decara needed further surgery. So arthroscopy, synovectomy, and partial trapezotomy is also an option, and interposition of tendon slip, but it's for the more advanced CMC1 osteoarthritis, and then for sure you can do an LTI or prosthesis as well. Here we can see one case, sorry for the bad video. Arthroscopic partial bone resection, once again partial bone resection. And here we can see sticking out some peaks of the bone, like here, and this is very important to remove, like we can see here nicely. You can do an interposition of the distally based partial APL, and to fix it just on the palmar capsula with a kind of meniscus suture. And revision options after arthroscopic treatment are very widely. You can anyway do the LRTI interposition or even prosthesis if you do only a resection of a small amount. So very small resection maintains central bone structure, as we can see here. After synovectomy and fat grafting was going with this prosthesis. I just want to keep in mind that the treatment of the comorbidity, it means the instability of the MCP1 joint, is also important. We may have a look on this publication. So in conclusion, stage-oriented therapy, patient-oriented therapy, and we have an algorithm like this. Now we can see we have a very good options for different stages, and a lot of them are arthroscopic procedures. But anyway, if they are not working, we have still all the other ones. Thank you very much.
Thank you. Nice talk. And really, like arthroscopy, we don't burn any bridges, and We can all the options afterwards. Any questions from the panel for her? Meanwhile, because we're getting, there's a question to PT from Dr. Parag. He wants to know, like, would you recommend trapeziectomy in patients who are age group of 50s, or you will consider doing LRTI along with it?
PT Chan is not online. I don't think.
Yeah, okay. Anyone can, I would like to answer on that. Abhijeet?
And Eva, do you want to answer that, Eva?
Yes, I can do. I think the LRTI is not that much the question regarding the age. I think it's more the question if the capsule is very stable and when you close the capsule, you have still a distance between the first metacarpal and the scaphoid, then I think it's okay. If you have the impression that the first metacarpal is falling down directly, then I personally prefer an LRTI, but it's not depending on age in my personal view.
Okay. Any question for Eva?
I have a quick
Can I ask a question?
May I ask a question?
Yeah.
Eva, do you the fat injection that you give after the trapeziectomy, arthroscopic hemitrapeziectomy, how do you process the fat? Do you centrifuge it? Do you kind of just aspirate and give it?
Sorry, I didn't understand you very well. So
the fat injection, is there a process?
Is that a?
Do you centrifuge the fat? Do you?
Abhijeet, your voice is dragging. Eva, he's asking, how do you process the fat graft which you took?
It's
what
just.
Do you sediment it, or what do you do here?
Yeah, it's just sedimented because there are some difficulties regarding the medical law also to put the fat in the joint in Germany or even in Europe in most of the countries. So if you make a product of it, then it becomes more difficult. And I do just a sedimentation. And I don't add it when I do a partial resection of the trapezium. It's only if I do synovectomy and remove small loose bodies or something like that, then I put the fat, but just sedimentation.
Thank you.
Thank you. If there are no questions, then we move to our next talk.
Can I ask a question, Eva?
Greg has a question, I guess.
Eva, thank you very much, Eva. Can I ask you about the fat again? So how much of an advantage do you think that is? Is it, where do you think it's wrong? It described when you think it should be used, but how much of an advantage do you think it is over not putting the fat in there?
Greg, I just get the first part of your question because then you was muted.
Sorry. How much of an advantage do you think the fat is in those cases where you think it's indicated?
Yes, I to be honest, I don't know. But the donor side morbidity is that slow that I think we can use it anyway. But to be honest, I don't know it. And we have results that are very, very good, but we have also results that are not that good. And until now, I don't have really a point where I can predict it. What we need is time. It's really something we need to wait enough. And if the people are not patient enough to wait at least, I would say half a year or even longer, we see that over the long term, they're getting better. So probably the failure rate is at the beginning. And then most of them, they was going on for 2 years or longer. They are not coming back for another procedure. But at the beginning, in the first year, so I don't know what is really the point. Thanks for the question.
Thank you.
Thank you. Any other questions? So we move to the next talk on arthroscopic partial trapeziectomy resection and FCR suspension and interposition for CMC arthritis by Dr. Shu
Today
Jin.
we'll present the topic is arthroscopic partial trapeziectomy and FCR suspension interposition for basal joint arthritis. For anatomy of a basal joint is the saddle joint. Yeah, it means that it's very instability, easy to mean instability. Surrounding the joint have the cysteine ligament surround here, and the most important, the ligament for stability is the L and DRL. For female, it's smaller and thin cartilage, so it's the reason why the female always easy to get arthritis here. So for treatment, the arthritis basal joint always consider the conservative treatment, but it's fair to consider the operation. We have two criteria should be cured. One is disability, one is Earton stage the basal joint arthritis from 1 to 4. The stage 4 is the most important, is the ST joint involved. The most patient need to operation in stage 2 and 3. For old standard procedure for basal joint arthritis is to take out the whole trapezium and do the suspension arthroplasty. So use the FCR or use the APL to make a tunnel here or web between the ligament. Many kinds of the tendon suspension have the report. They all get out. So we use arthroscope partial trapeziectomy, and at the same time we use FCR to do the suspension interposition in our series. The indication is for elder stage 2 and 3 and fail post-conservative treatment. First, we use the FCR distal base tendon graft. The diameter should be largely 4 mm. Then we do the arthroscope partial trapeziectomy, especially we take out the medial size of the trapezium. Then we do the thermosynclature of the volar ligament and apply the soft anchor to the medial size and do the FCR suspension. We use FCR to web to the APL through the joint. Then the residual FCR will make a tendon ball put inside the joint and use the anchor to fix the tendon ball and also catch the APL to make the internal split. Then we KY to fix the 8 to 6 weeks. Is a 52 years female. Is with stage 3 basal joint. First, we use the FCR distal basis, the tendon graft, the right side picture here. Then we check in the joint and the endoscope. We can see all the culture is well. It's stage 3 at least. And then we use the osteotomy is to remove the medial size the trapezium. Then we use the burr to take out the partial trapeziectomy hole, the trapezium, and also the medial side. And then we do the thermosynclature on the volar ligament here. Then we apply the soft anchor. Then we make the FCR through the volar portal to the 1R portal and to web the APL here, the right side inferior the picture here. Then we back to the volar portal and we suture here and then make a residual. We make a tendon ball and put inside, and then we anchor the fiber wire or rainbow tab to shoot tendon ball. And we can see the picture, the arthroscope, the soft tissue put inside the joint, and then we use the pusher to tie and fix the tendon ball. After that, also use the catch the APL to make the internal spring. Then we use KY to fix the AV. And 3O help ear better. We can see the good range of motion and give the power. 2 is the follow-up. We can see just 1 mm post migration. I think it's a good suspension is a good method to keep the stability. We correct the 25 case, and mostly it's the female, and mostly it's the stage 3 arthritis by Eaton stage. Synovitis, and finally take out the medial side trapezium and the partial trapeziectomy performed, and put the software inside. Emphasize that the medial side should be removed here. How about result? Yeah, with the pen score, the strength and power range of motion improve very much, and 2 minutes for small migration, but it's okay. our series result is better than open procedure. In our series, yeah, is we put a subtissue in the joint. The result is a little bit possible migration 2 millimeter, but I think its function still is okay. Take home message. I think it can activate the resection, the spur, and the trapezius over the first and second metacarpal area. That's very important. It can improve the range of motion and also the symptom relief. Use the soft anchor is very important for us because we can fix the tendon ball, and also we can give the internal spring and so improve the stability here. I think it's a good, the excellent result is, I think it's better than, a little bit better than the open procedure in our series. The technology, I think, is not difficult, it's easy. It can keep the better joint capsule intact and also save the surrounding ligament. And the soft tissue imposition is very important in our series because it can tension the ligaments around the better joint, make a good strength and increase the stability, and also treat the arthritis. A little bit of proximal migration, I think, is okay. In our series, 1 year, 2 year follow-up and just 2 millimeter. I think a good method to treat our patient. You can go over the video. You can see that we take the spur and the debris between the first and second, the very best area, the medial side of the trapezius area. I think they're very important. Symptom remove.
Thank you for the nice talk.
Thank you very much.
Yeah, any questions? Question from Jeff. Jeff, would you like to answer? Ask your question. Partial trapeziectomy versus total.
No, I'm fine. It was just a question of, has anybody got any data or experience with partial excision of the distal trapezium alone, the complications and how it relates to the other operations? PT Jam isn't available, so I addressed it to PT.
Thank you. Thank you, Jeff.
Thank you. Thank you, Dr. So if there are no questions, can we move towards next talk?
Yes, I'll bring it up.
Yeah, it's a founder's lecture. How did wrist arthroscopy change the world in the past 36 years? By Dr. P.C. Ho.
Thank you very much for the kind invitation of organizing committee for me to share my view about the wrist arthroscopy in the past 36 years and the focus on how it changed the world. The first clinical application is actually dated by almost 50 years ago by Professor Watanabe, and he was already using his arthroscope in the 70s. And in 1978, Dr. Chen Yongzhen published the paper, and the 90 examination is a very important paper. Actually, when you look at detail, it's interesting to see that various types of the arthroscopy have been done even on the finger joint. And they're using the portal is very similar to what we are doing today. It's an indication of mainly rheumatoid arthritis, and simple things like diagnostics or punch bobs have been performed. Very interestingly, we also noticed that 70% of this operation actually done by under local anesthesia. So under local anesthesia is actually not a new idea. But I think the true landmark paper is actually by Dr. Tahir, who actually standardized the technique of wrist arthroscopy in 1986, and which affects every part of the world. So over the last 36 years, wrist arthroscopy has elevated steadily from a diagnostic instrument to resective surgery to reparative surgery and to the forefront, reconstructive surgery. So how it changed the world? First of all, I think it's actually create a new diagnostic standard. Now, virtually all intraarticular pathology, the gold standard is still on the wrist arthroscopy. Consider the rarest type of synovitis. Crystal deposition sometimes can be a diagnostic surprise, but it can easily reveal under arthroscopy. chondral lesion, ligament injury, carpal instability, TFCC injury. Against the arthroscopy has a non-replaceable position. It also enables a new surgical approach to be created. Using the minimal invasive surgery approach, we can minimize the damage to the soft tissue and blood supply, and also best preserve the proprioceptive function of wrist. It has been applied in resective surgery, reparative surgery, and reconstructive surgery. Like the scaphoid fracture, nowadays you don't really need to open up the wrist. You can actually reduce very difficult and display the fracture under direct vision, particularly in mid-carpal joint, and you can actually create a very stable fixation. TFC repair, you can create different type of method, capsular, transosseous. To the footprint reconstruction, you can do inside out, outside in, or inside. Very precise control the TFC repair. For partial wrist fusion, nowadays you really no longer need to open the wrist joint. You can virtually fuse every segment of the wrist and preserve the maximum function, while at the same time preserve the best cosmetic outcome. In TFC reconstruction, the bone tunnel can be created without opening the wrist joint. You can actually pass the tendon graft through the bone tunnel very precisely and contribute this position. And now even this is all arthroscopic version has been designed out, which is actually has continued to improve the surgical technique. Thirdly, I think this arthroscopy actually enables some new surgical idea to be created and create some new concept and approach. For example, in the field of ganglion surgery, bone grafting, scapular ligament reconstruction, etc. So Dr. Lee Osman in 1995 discovered importantly that the ganglion can be tackled inside the joint through the scapular ligament capsular junction. You can actually excise the ganglion with a very small incision. In 1997, also found that in volar wrist ganglion, you can also reliably go to the interligamental sulcus area to decompress the ganglion, and in this way you can decompress a very large ganglion with a very tiny incision. So this is also a breakthrough in the ganglion surgery. Arthroscopic bone grafting proved to be a very effective method to deal with the non-union by preserving all the biology and the blood supply. You can reliably heal the non-union. Even for difficult DC deformity, you can use specific strategy to reduce the DC deformity. You put in plenty of bone graft to fill up the volume and to restore the anatomy of the scaphoid. In scapular ligament reconstruction, you can also reliably control the ligament using bone tunnel without the risk of causing avascular necrosis of the scaphoid. So even for very large diastasis, scaphoid subluxation, you can reconstruct the scapular stability very reliably with this technique with very good long-term outcome. Fourthly, it create a new understanding on DC. For example, in scaphoid distal fracture, with the use of arthroscopy, we now understand that much better about the ligament injury, which is very high incident in this sort of fracture situation. In the Kimball disease, we also enable new developed articular-based management approach. Now you can actually visualize the cartilage. We realize that actually the problem of the cartilage damage is actually originated from the subchondral area, where even the cartilage look a bit intact, but in fact it is non-functional. This actually forms the base of articular-based management for pedicle management of Kimball disease. Fifth, I think it's actually create a type of new doctor-patient relationship, particularly when you perform the surgery under local anesthesia with no tonic sedation. You can freely communicate with the patient, enable the patient to directly observe and understand the pathology under direct visualization. And this is very important for sharing information and sometimes in the clinical decision-making, particularly for these difficult cases. Six, I think it creates some new training model because arthroscopy simply requires a new skill set, which is actually not used to be done by the hand surgeon. It requires special eye-hand spatial coordination. And therefore, it actually encourages the formation of very cadaveric workshop, which is the best way for the young surgeon to learn the technique. It is actually very fascinating to the new generation. And the recent technological development actually expanded possibility like the use of robot, navigation, AR or VR. And because of this, actually a global serve and the risk interest through the many risk arthroscopic cadaveric workshop all over the world, it bring people together to learn this new exciting technique, which can be very helpful. 7, I think with the emergence of the risk arthropathy, even some new profession can come in because there's an increased inclination towards some sport-related problem. And for some sport hand surgeon, upper limb surgeon, you can simply use the arthroscopic-based surgical expertise. You can actually already can help a lot of patients and survive on this arena. And there's also, we see increasing collaboration between the sport and hand surgeon, like in the ESACOP, or even the Chinese Sport Surgeon Association has recently formed a hand group within the sport surgeon. Finally, I think, and very importantly, is about the new collaboration, the possibility to actually bring people really together. Through the EVAs, we know the WIW, of course, APWAs in our locality. And I think this actually brought through some cadaver courses, fellowship programs, conferences, arthroscopic tour, web teaching, interactive forum, journal publication, database, modules, center and study, etc. The recent formation of IVAS is actually one step forward because it actually enables a true international collaboration work together. So you know that is happening in 2015 in Hong Kong. We celebrated the formation of the airplanes, which is an important step going first improvement of the safety in content. So isn't it an exciting moment? For sure, it is very memorable for me. So subsequently, we organized many very successful congresses, like in Beijing 2016, Adelaide 2017, Larita 2018, and Seoul 2019. Even in the coming of the COVID time, which created very difficult moments last year, I think with the great leadership of Professor Wen Dongxu, we organized a hybrid meeting in Shanghai for the 6th Congress, with also very engagement of not only the local surgeon in China, but also many international faculty members. This is a really very special situation. And we also, through this APWA, we create a traveling fellow. Now we have many young generation has been engaging, and in fact, we have also happen to see some of these fellows already a key member now in the APWA's core group. So I think this is really exciting and very encouraging. We also see a global publication of risk is actually escalating through the formation of this organization. And in fact, in the last 5 years, there's been about 377 papers published, and it's very exciting to see that in fact 65% of these publications actually are arising from the Asian area. So we should be proud of all this achievement. So for sure, arthroscopy is far more than just a technique because it enables a better understanding of the disease, enable new concept treatment. There's the improvement in the skill set and tool, minimize the downside of surgery, enable innovative thinking, and importantly, changing our mindset. But please remember, arthroscopy is not everything. The research is evolving. There are still many, many things going on, like small joint arthroscopy, 3D printing navigation, ultrasound guide surgery, fracture and implant, arthroplasty, microsurgery, open surgery, particularly in the use of the voluntary, and other technology like nanotechnology, healing agent, biomechanic, neural control, rehabilitation, etc. A lot of unsolved problems that yet for us to go on to take the challenge is because we have seen the ever-rising patient expectation. Okay, because patient will prefer motion more than fusion. There's an increasing demand on the minimally invasive surgery and ambulatory surgery. The patient cannot wait for inpatient care, particularly in the time of COVID. We have more attention on sport-related problem and degenerative problem. Patient will have more concern about the scar and appearance, lesser scar, better. And asking for quicker recovery and rehabilitation, and the information will spread through the internet. So the surgeon, we have to well prepare ourselves to help the patient in the best way and the most modern way. Lastly, I really feel very honored to be the founding president of this very important organization. I always treasure this position for being able to serve everyone, have the honor of being trusted of you, and the privilege of learning, being inspired by all my friends and all good friends and all the master throughout the years, with the many, many happy moments I remember. So I think APWA must go on because we need to expand our membership. There should be more international participants for the APWA congresses. There should be more publication at the Journal of Research and other important journals, the better coordination within the risk course within the regions. We should solicit more commercial support. We should better use our website, the media, for sharing of knowledge, experience, and vision, expanding our travel fellowship program, enhancing international collaboration, and so on. So it is really an association for all risk lovers, and we must need to engage more young people to join us our profession. And Viva APWA.
Thank you, Dr. Nice talk. Abhijeet, would you like to have any comments on it?
Yes, PC, thank you so much for your vision,
My pleasure.
for your leadership, for your sense and your spirit of inclusion and inclusiveness. I think your stewardship of the wrist joint and surgery for the wrist and calling it more of a wrist association, it is more of a wrist lovers association. It strikes a chord, I think, with every one of us. It resonates. The spirit, the concept resonates with all of us. You have done a stellar job bringing people together and helping us expound and propagate on the field of wrist surgery. I'm very grateful to you and very proud to call you my friend and mentor. Thank you so much. I would also invite our senior colleagues in the webinar, Jeff Ecker, Eva Maria, Bauer, to please say a few words in honor of PC Ho, please. Thank you.
Ava, would you like to go first?
Yeah, and Greg is also here, so please, all three of you, I would really appreciate it. Thank you.
Yes, thank you, PC, for learning us and for the friendship. I had just the pleasure to have you here in my hometown 2 or 3 weeks ago, and it was a very nice trip. And thanks for everybody here for sharing the knowledge, but especially the friendship. And I'm happy to be part of it. Thank you, PC, but thank you to you all.
PC. Jeff Ecker, from all of us, what an extraordinary thing APWA is. I don't know if people appreciate how you brought this together so quickly. You got us all to work as a team, and my observation for PC is he is one of the greatest team builders. He builds teams, builds bridges, gets people working together, and is a wonderful leader, because not only does he share his love and his enthusiasm, he gives his friends accurate feedback in the moment. And sometimes that is difficult, but we all learn from that. We learn from the way we conduct ourselves, the way we research, and how we work together. And I thank PC, because it's a bit like his music. Music is his world. He's turned wrist arthroscopy into like music. We're all friends. There's no differences. We all work together. So PC, thank you. What a treasure you are.
I'd like to say a few words as well. PC, I've known you for almost 30 years. I've learned so much from you. You've been a wonderful leader. I think you've united and taught everybody in Asia hand surgery and wrist surgery, but not just there, all over the world as well. You've helped bring IWAS into Asia, but you've created the new APWA. Really, PC, you've been a legend, and we're so grateful for everything you've achieved. And I think we all owe it to PC and everyone in the group to continue the legacy that he started. PC, thank you very much for your friendship, for teaching us, and for being a great leader for all wrist surgeons in the area. Thank you.
Thank you so much for all the kind words. I think you are just too much to me. Yeah, I think as a humble man, as a humble friend, and I would just like to enjoy all the friendship that we built up over the years, which is actually a treasure as much as what I learned professionally. I think this is really the fun of being together. I think it's just a simple thing. The wrist is so fascinating, particularly when I first learned about the wrist about 25, 30 years ago. it was really so little to know at that time. But with all our effort, all our work, hard work, and the enthusiasm towards the risk, now we learn much more. So I think this is also facilitated by because we are getting together. Only through this only means that our knowledge can grow, our experience can grow together, and we can help our patients in a much more effective and efficient way. So I think thanks everyone to be here, and I would really glad to see so much love in the risk has built up in different society in the Asian Pacific area and also globally. So this is really wonderful to see. So we must go on, I think there's still many things that we can work up to get a better way and better life. And I'm sure that our friendship will continue to glue together. So thank you very much for being here.
Thank you, PC. I would also request the president of the APWA, Dr. Wendong Xu, to please say a few words. Dr. Xu? Professor Xu, are you here? He was online just a moment ago. Yeah, he's still online. I'm not sure if he is around. I think Bo Liu is here on behalf of our Chinese colleagues and Professor Wendong Xu. Could you please, Bo Liu, are you around? I'm not sure if they're around, but all right. Thank you so much, Professor Ho. It was a fantastic talk, and the summary was really well worded. We all enjoyed it. Thank you for everything. Shall we then move on to the next session now, please? I would like to invite Anil Bhatt to please take over the proceedings. Thank you.
I think Vinit, are you around for the next session?
Yeah, he's here.
Yeah. Vinit, can you start the session, please?
Thank you. Thank you, Dr. Amit.
The session is on. Vinit, you're not audible, Vinit.
Is it okay now?
Abhijeet, can you share the first talk, close reduction and pinning technique for peri-lunate?
Yes, right.
Good morning. I'm Wang Zhixin from Beijing Jishutan Hospital. Firstly, I want to thank the committee for inviting me to attend our annual congress. My topic is peri-lunate dislocations, close reduction, and pinning technique. As we know, peri-lunate dislocation and peri-lunate fracture dislocations are complex types of wrist injury, which usually result from high-energy accidents such as falling from height, confrontational sports, or motorcycle accidents. This injury includes severe and extensive bone and ligament damage, resulting wrist disability even after treatment. The open surgery used to be regarded as the gold standard of treatment because in open surgery, you can check the ligament and the bone injury, perform reduction and fixation under direct vision, and repair or reconstruct the injured ligaments. As for the approach, volar, dorsal, or combined, the decision mainly depends on surgeon's preference. Although many surgeons prefer open surgery as their first choice, it is not perfect. Apparently, Extensive exposure may further damage to an already fragile blood supply to the carpus, especially scaphoid and lunate. Open surgery may also introduce more scar tissue and can aggravate capsular adhesion and impair functional recovery. In addition, scar of the incision affects the aesthetics. Actually, close reduction and percutaneous pinning was taken as an alternative to the management of peri-lunate injuries for a long time. The fracture dislocation was close reduced under anesthesia, and then fixed by screw or wires and fluoroscopy in a percutaneous way. The alignment of the carpus was maintained by K-wires, and the injured ligaments were healed spontaneously during postoperative immobilization. Recent studies have given evidence to support this closed technique. A systemic review compared the results of open surgery and the closed reduction and fixation. They concluded that the closed technique offers slightly better outcomes than open surgery. Several case series also achieved a favorable short-term outcome by using closed technique, and concluded that the percutaneous procedure is a successful treatment. Closed reduction and the pinning technique has several theoretical advantages. Firstly, most of the PLD and the PLFD can be close reducted. The closed way introduces less scarring and blood supply damage, and the injured ligaments have potential to heal as long as the correct carpus alignment was maintained. Besides, there might be less complications related to incision, and the closed technique can result in better cosmetic results. There are several technique tricks when performing closed reduction and pinning. For this most common type, the dorsal dislocation, the reduction begins with traction. You can apply a counter traction with an assistant or apply a continuous traction. During traction, the wrist is extremely extended to increase the dislocation. At the same time, use your thumb to locate the volar edge of the lunate, and then push the lunate to relocate while flexing the wrist. Because the intercarpal ligaments were ruptured, the alignment of the carpus are still abnormal after the dislocation has been reduced. In lateral view, we can notice that the scapholunate angle increased due to the lunate was in an extended position. Under fluoroscopy, we flexed the wrist to correct the lunate, then fixed the radius and lunate by K-wire temporarily. After that, we extended the wrist to neutral position. We can see the scapholunate angle was corrected. We can also correct other abnormal alignment by using similar joystick techniques. For this case, we used double K-wires to fix the scapholunate and the lunar-trochanteric joint. Also fix the radial siloid by one screw. For transcaphoid peri-lunate dislocations, we usually fix the scaphoid after the dislocation was reduced. You may find that the reduction and fixation of a scaphoid fracture in transcaphoid peri-lunate dislocation is more difficult than fixation of a simple scaphoid fracture. That is because the lunate is unstable and the proximal pole of the scaphoid is unstable too. Similarly, you can fix the lunate to the radius temporarily if necessary. After the fixation of the scaphoid, the rest part is the same. So in this greater arc injury, the general sequence is fix the fracture first and then fix the joint. The way of intercarpal joint fixation varies across the literatures. I think the choice was mainly up to the surgeon's preference and the specific situations in different cases. This one is a typical case that we managed by close reduction and percutaneous pinning. The patient is a 29-year-old male, got injured during a football match. The close reduction and the fixation was performed 6 hours after the injury. At the 6 months follow-up, the patient got a painless extension flexion arc of 150 degrees. The grip strength recovered to 85% of the injured side. From the X-ray, we can see that the alignment purpose was well maintained. Certainly, the closed technique is not suitable for all cases. Occasionally, we may come across some atypical cases, such as the palmar divergent type. The lunate rotates volarly more than 90 degrees, or even dislocates to the forearm. These types of peri-lunate injuries do not fall into Mayfield classification and usually are difficult to be reduced by closed way. And apparently, the chronic cases are not appropriate candidates for closed technique either. This kind of peri-lunate dislocations all cause for open surgery. Okay, thank you.
Thank you, Dr. Wang, for excellent talk. And we have a question. How do you control the scaphoid rotation while reduction and pinning? Dr. Wang?
I'm not sure if he's around.
Okay.
Can one of the co-authors take up that question? I think they're not logged in. Shall we move on to the next one, Vinit?
Yes, the next one is open repair technique by Dr. Ravi Bhardwaj.
The patient is a young male who fell from a height, sustaining injury to his left wrist. X-rays have revealed a transcaphoid peri-lunate dislocation of his left wrist. Closed reduction is attempted by using the Taverniers method. So this is a transcaphoid peri-lunate dislocation, and the method of reduction of the lunate is same as in peri-lunate dislocation, the Taverniers method. So hyperextension of the wrist with longitudinal traction. Put your thumb on the lunate and push the lunate forward, and then gradually flex the wrist, and you hear a clunk, and that's the lunate back in place. Now we'll take a picture and see whether the lunate has been reduced. So this is the lunate back in place, and we have reduced it using the Taverniers method, which I have just described. So this is a standard dorsal approach to the wrist, centered over the Lister tubercle. It's approximately 8 centimeters long, and we can extend it in either direction as required. And the plane in which we enter the wrist joint is between the third and the fourth extensor compartments. So you can see that this is the extensor retinaculum. If you notice obliquely, this is the EPL tendon. You can see that when I'm moving the thumb. And we will incise the retinaculum here, reflect the EPL radially and the fourth compartment tendons ulnawards, and enter the dorsal capsule immediately underneath. So this is the dorsal capsulotomy incision which we have planned. We have retracted the tendons. So what we have here is the dorsal capsule. So we're going to raise a radially based flap like this and reflect it towards the radial side. We are about 2 millimeters of capsule we are preserving from the distal radius to stitch it back to, and this should be the outline of the capsulotomy. So we are completing our radially based capsulotomy and reflecting it, and now we've got a rectangular flap of capsule which we are reflecting radially, which gives us a very good view of the underlying corpus. You can see the fracture site, you can see the lunate, the scaphoid, everything here, as well as the fracture site. Longitudinal traction on thumb for scaphoid reduction. So we have reduced the scaphoid and passed the guide wire and checked on 3 views on the C-arm, and we are quite satisfied with the position of the guide wire. We have measured the length of the
cannulated headless compression screw to be 18 millimeters, and that is the length of the screw which we are proceeding to fix the scaphoid fracture with. So this system of cannulated headless compression screw has 3 marks: the green, which is the screw sitting 2 millimeters proud, and then the yellow. If I turn it till the screw reaches the yellow margin, then that's the end of the head of the thread flush with the bone, and then I need to advance it a bit more till the red mark, and that's the screw 2 millimeters buried within the bone, the head of the screw. So you can see that we have achieved fixation with the headless compression screw of our scaphoid fracture, and we have achieved a hairline reduction, as you can see, and we have confirmed that radiologically on the CM pictures in 3 views as well. So this is the scaphoid which we have fixed. This is the fracture site which is anatomically reduced. This is the scapholunate ligament, and this is the lunate which you can see here, the shiny bone here, and I have exposed the scapholunate ligament and it is intact. When I am probing it, there is no gap or diastasis between the lunate and the scaphoid. So it was a trans-scaphoid peri-lunate dislocation, but the scapholunate ligament is intact. Now, because there was dislocation of the lunate, I am suspecting there will be lunotriquetral ligament injury, and this is something which we have to repair. This is the lunate, and this is the triquetrum to the ulnar side, and this is the capitate distally, and I think the lunotriquetral ligament has been torn here and it's avulsed off the lunate, so it's a bony avulsion with a little bit of soft tissue. Let's see what we can do to fix this back. So this is the lunate with the lunotriquetral ligament which has been torn, and this is the triquetrum, and you can see that there is instability between the lunate and the triquetrum, and this needs to be addressed by a combination of K-wires and soft tissue repair. A bioobservable suture anchor 1.3 mm is used. Sutures have been passed into the lunate and the triquetral ligament has been repaired. This is the lunotriquetral ligament repaired along with the dorsal capsule. This is after the repair. Some final pictures taken on the CM in PA, lateral and oblique views. The K-wires and the plaster are retained for 6 weeks post-op. This is 3 months follow-up with satisfactory wrist movements.
Any questions for Dr. Ravi?
The point which I wanted to make, and the reason for sending this video is just because the open technique is still very much relevant in our scenario, especially where many of these injuries are dealt by orthopedic surgeons who don't necessarily have the necessary skills to tackle them arthroscopically. And what I'm trying to show is a very simple, reproducible technique which can be adopted by anyone who even doesn't have that kind of expertise in, arthroscopic wrist surgery. That's the point. Yeah.
There's a question from Deepthi. The lunocapitate ligament repair and possible.
Yes. So this is a tendency where I would normally usually I use a couple of additional wires in this X-ray. This particular case I haven't, but normally Deepthi, you got a point. I would put an additional wire, and wherever possible, the lunocapitate ligament was repaired, but the repair itself felt very stable. But normally I would use a diamond configuration kind of K wires. Yeah.
Thank you. I think Dr. Tahir Ansari is online now as well. He is as well. May I invite or may I ask Dr. Ansari to please do the honors? Thank you.
Thank you, everybody. I think we should proceed for the next talk. There was one more question from Dr. Deepthi. What to do with the multi-segmented triquetrum associated with the injury? So Dr. Ravi, any views on this? Multi-triquetrum associated with the injury?
If you feel that the triquetrum is, I mean, even if it is multi-fragmented, I think we can sort of repair it with multiple K-wires, and even in the best of results, if the repair, we have a little bit of persisting lunotriquetral instability. So in the primary instance, my preferred technique would be to fix it with smaller K-wires, or retain the triquetrum. I wouldn't be doing anything more than that, at least primarily. But I would always inform the patient that an additional procedure may be required in the future.
Sometimes there is a volar fragment from the triquetrum. The lunotriquetral has a one from the volar side.
No, then you might have to see. That is where a CT is very evident. I just showed this as a one-off case, but normally in a part of a workup, I would always do a CT, assess, and keep the option of an open volar approach also. And sometimes this capsular tear in the volar approach might need an additional approach. Sometimes the patient might have pre-existing median nerve symptoms. So you have to keep an open mind about a dual approach.
Thank you, Dr. Ravi. So we move for the next talk by Dr. Herzberg regarding arthroscopic assisted pinning technique.
Cette conférence va maintenant être enregistrée.
Marion Burnier.
Guillaume Herzberg.
Hello from Lyon. We are happy to present this topic
about peri-lunate injuries management. Arthroscopy is the way to go.
We try to convince you.
This is the outline. And first, of course, we know that peri-lunate injury is a spectrum of different injuries, as described by Guillaume several years ago.
The question is, do we need arthroscopy for all peri-lunate injuries?
That's why we identified two ID, ID1 and ID2, and of course in ID2 with some enucleation, this is not for arthroscopy.
We have to start, Marion, from the pathology, not from the treatment.
In ID1, there is three different scenarios. The first is a successful closed reduction.
Next, it might be irreducible.
And then, of course, the peri-lunate injury non-dislocated, which was spontaneously reduced.
First of all, you put traction, a little bit of intracarpal pronation, and you reduce the peri-lunate injury. What's next?
Of course, the CT scan, and especially in this case, we are happy to perform the CT scan to be able to see these triquetrum injuries and the fracture.
Next.
The principle of repair with the scaphoid fixation and pin fixation.
And isn't there a best exam to diagnose a combined scaphoid fracture and scapholunate injury, as outlined a long time ago by Mayfield?
But what about the radiolunate key wire? This is often a challenging topic, and we believe it is very useful because if not, and if there is any ulnar translation, this is terrible for those young patients.
It's not mandatory, but it's very safe adjunct.
And of course, we have to take into consideration the lunotriquetral dissociation.
Now the sequence.
We are very happy to describe the sequence. And for the pure ligamentous, the first key wire is the radiolunate key wire, radiolunate fixation. For the transscaphoid, of course, we fix first the scaphoid.
And now let's compare on our left the ORIF and right the benefits of arthroscopic assisted or pure arthroscopic fixation.
We know those different open approaches from Pierre, then Guillaume, and the last one from Loisel and Wolf.
Of course, you have a very wide evaluation, but look at the good view you have from inside.
And this bare area on the dorsal side of the wrist. And with only, at the beginning, with only two small incisions on portal, you can introduce your scope. And of course, at the beginning, we don't see very well when you just go. As you can see on the left side, this is, of course, images in the beginning. But even with dry arthroscopy and after automatic washouts, this is in few seconds what you can have.
So you see more with a less invasive procedure.
You can also see some loose bodies and eventually remove them.
Of course, you can have a comprehensive visualization, but look at the approach. It's a huge approach compared to this.
A radiocarpal view first, where you can assess, start to assess the scapholunate injury and the different lesions, even sometimes association with some TFCC lesions, like in this example.
That you just ignore when you are open.
Of course. And then you move to the mediocarpal
side, and you see the scaphoid gap, the huge gap of the fracture. You see again the scapholunate interval, and you see very nicely in seconds the proximal pole of the capitate, which is an important prognostic factor. So you see many things, and
then it's time for fixation, and sometimes you can associate this arthroscopy with a mini open dorsal approach, so you can achieve a good reduction, appropriate reduction of the scaphoid.
AARF.
Some pure ligamentous, it is also useful to perform. You can see a very mini dorsal approach from your 3-4 portal, so you can perform with anchors, scapholunate repair and dorsal capsulodesis.
And you have focused on the true injuries with the initial approach.
And in some cases, if you have a good colleague with you, as in this case that we perform together, Guillaume, it was possible to make it all arthroscopy with first, of course, evaluation, scapholunate. You can see that there was no scapholunate dissociation. We can see the loose bodies and remove them, of course. And finally, perform the fixation with the first 2K wire and finally with the screw fixation.
Don't worry, it doesn't look perfect on the arthroscopic view, but there is a magnification, so it's good enough.
And we are still working on some devices to increase and improve the fixation and the time of fixations, for example, in this case with the lunotriquetral fixation.
A case where open is really a challenge, what would you do in this case?
Which approach, which kind of fixation, what is the good angle? In this, you use the 6U portal for fixation, actually.
It's really the best way to go. As you can see here, you reduce with the 3-4 portal and you just pin the lunate, and you have the exact trajectory without disturbing anything else. And of course, you add the radial stylet.
Another scenario with irreducible injury, and for that there is a very great paper from Beaulieu.
Yes, he showed nicely how you can reduce even if it's irreducible using your scope. And now if it's spontaneously reduced, as in the plane the injuries, look at this case.
Okay, this is young patient with a high energy injury, and you can see this chips bone fracture on the X-ray or the CT scan. When you see that, okay, you can say this is probably a plane, and for this arthroscopy is very useful.
Could you believe that you will find this?
This lunotriquetral dissociation, and then when you move to the other side, you can see also scapholunate dissociation. So this is the association of those two ligamentous injuries. Some chips bone fracture, the scapholunate injury. And this is good not only for diagnosis, but also fixation.
Now, we showed that it was useful in 3 situations.
And this is from what we come to what we get with the help of arthroscopy and 4 small portal and incisions.
So we hope you convinced all of you about the use of arthroscopy in peri-lunate dislocations. Thank you, Marion.
Thank you, Guillaume. Thank you, everyone.
Bye-bye. Thanks.
Have a great meeting.
Thank you, Dr. Herzberg. Thank you, Marion. Very interesting technique and very interesting way of presenting it. We definitely loved hearing from you, Dr. Herzberg. Very innovative technique. So any questions? So my question is one regarding the timing, basically. What will be the right time to proceed in these cases? Whether first day, second day, third day? Because I think in the initial days, first 2 days, we will have a lot of hematoma. So should we do it on third day or fifth day, seventh day, or within 48 hours? What's your views, Dr. Herzberg, regarding this?
Neither Dr. Herzberg nor Marion Brunier is here, but Beaulieu is around. If Beaulieu can answer that question, if he's around, or anyone, Jeff or PC, if you can please take that question. Thank you.
I'll answer because nobody else is at the moment. I believe these should be fixed straight away. And I believe the arthroscopic technique is extraordinarily good for this injury. As you can see, it was so beautifully demonstrated what you can see. And you can repair a lot of these things, well, most of them arthroscopically with suture techniques and anchors. And that's the best chance of getting the best result. Identify the pathology clearly. And you can only do that with arthroscopy. Anatomically fix the damaged structures and then start rehabilitation to move the hand straight away. These are very bad injuries, but with these recent advances with arthroscopic surgery and our understanding of the injuries, the outcomes are so much better. So I think that was an absolutely beautiful talk, and it showed you what you can do with arthroscopy. And it wasn't the arthroscopy, it was the understanding of the pathology and the injury and having anatomically directed treatments. And I think you can't beat that.
One question, Jeff.
Anything regarding the timing of surgery, whether we should do within 48 hours, after 48 hours?
Straight away.
Straight away.
I don't have, unless you've got some horrendous soft tissue injury that needs a free flap and the swelling is absolutely gross, straight away. The earlier the better. You know, but you need to be wise when you do this. Sometimes there's some horrendous soft tissue injuries and you need to balance it with your wisdom and your practicality. But the sooner you do these, the better. If you get them straight away, there's less swelling. I think some of the techniques for reduction that have been shared are very, very good, because sometimes they can be a little bit difficult to reduce. So it's a bit like free flaps. Is you had to wait 2 weeks. That's nonsense. You go straight away with acute trauma. And I think it's the same for this, but others may differ. That's my opinion.
Thank you. Thank you.
Shall we go on to the next talk then, please? Vinit?
Yes, the next talk is about arthroscopic treatment of translunate and peri-lunate injuries by Esther Chow.
Thank you very much for the invitation. Today, I'm going to share with you the topic of arthroscopic treatment of translunate peri-lunate injury. Lunate fracture is rare. Only 0.5% to 6.5% of all carpal fractures are lunate fractures. And the most common type is the volar pole fracture. So can lunate fracture associate with peri-lunate injury? There are 3 most important papers on peri-lunate injury. The first one published in 1980 by Mayfield, which described the 4 stages of injury. The second paper published by Johnson in 1980, which classified the injury into the pathways of greater arc and lesser arc. And the third paper published in 1993 by Guillaume Herzberg, which reported 166 cases of peri-lunate injury. And all these 3 papers have no case of lunate fracture described. And then in 2008, Professor Greg Bain first introduced the translunate arc injury, which introduced that lunate fracture can be associated with peri-lunate injury. And later in 2013, Professor Kim Hersberg also reported 5 cases of lunate fracture with peri-lunate injury not dislocated. So lunate fracture can be associated with peri-lunate injury, although it's rare. Today, I'm going to share with you 2 cases of peri-lunate injury associated with lunate fracture. First case is a 23-year-old gentleman who is a manual worker, right-handed. He fell after a jump, landed on left outstretched hand. So there's a severe swelling and pain over the left hand and wrist. The X-ray shows there's a peri-lunate injury with a dorsal dislocation. And if you look at the lateral X-ray more carefully, you can actually see a small fragment, which is the volar pole of the lunate. So close reduction was performed for this patient. And after reduction, CT was performed. And now you can more clearly see the fracture of the lunate at the volar pole. So arthroscopy was performed. So arthroscopic reduction of the lunate is performed under arthroscopy by using a probe. So the probe is tried to rotate the dislocated fragment of the lunate by flipping it 180 degrees, try to reduce it back to this original position. And so you can see the fragment is now reduced. So a guide pin is inserted, and then the position and stability of the fragment is checked under arthroscopy, and the screw is inserted through a volar approach. This is after reduction and before the reduction. And then the scaphoid is fixed percutaneously with a screw, and then the LT joint and TC joint is fixed with K under arthroscopic reduction, and the patient is put in a cast. And then 6 months after the operation, the patient regained good range of motion, and also there's minimal pain and good strength and function. And then CT scan shows there's good bone healing and good joint alignment. The second case is a 35-year-old gentleman, IT worker, right-handed. He sustained a motorcycle accident with his left hand and wrist severely injured with pain and swelling. X-ray shows there's crowding of the collarbones, and you can see there's a molar dislocation of the peri-lunate joint, and there's a comminuted fracture of the scaphoid. And there's a subluxation of the joint, and there's a comminuted fracture over the volar pole of the lunate. So arthroscopy was performed, and arthroscopically we can find the volar pole of the lunate, but the fragment is too comminuted for any fixation, so we reduce it and then decided to put in an X-fix. So X-fix is applied and the joint is reduced, and the X-fix is kept for 4 weeks, and then K-wires is inserted to the scaphoid, the LT joint and the LH joint, and later changed to a splint for another 4 weeks. And 8 weeks, we can see that the lunate volar pole healed and the alignment is good. So we remove all the K-wires and start mobilization. And you can see the pre-op CT scan and the 4 months post-op CT shows a good alignment and healing of the volar pole of the lunate. And this is the X-ray 1.5 post-op, shows a good alignment. And here is the range of motion of the patient, which is satisfactory, and the grip strength and the pain is also good with Leon risk score is 94, which is excellent. So a review of all the literature of lunate fracture associated peri-lunate injury, we found a very interesting pattern, which is whenever there's a lunate fracture associated with peri-lunate injury, the direction of dislocation is more commonly in a volar direction. The most common pattern of fracture of the lunate is still the volar pole of the lunate. And other associated fractures include the scaphoid fracture in most cases, and then secondly is the radial styloid fracture. For the treatment strategy of the translunate arc injury, first, because the lunate is the keystone of the risk. So the first step, we should reduce and fix the lunate fracture whenever possible. If the fixation is not possible, then we should put in an external fixator, and then we should fix the other greater arc injury, and finally, stabilization of the ligamentous injury in the lesser arc. So in conclusion, it is important to recognize this translunate perilunate injury pattern. Arthroscopic reduction and fixation of the lunate is a feasible treatment option. The advantages of arthroscopic treatment include better preservation of blood supply and avoid avascular necrosis, better preserve capsular and ligamentous structures, and prevent arthrofibrosis and stiffness. Thank you very much.
Thank you.
Yes, there is, and if there are any questions, Vinit, can you please go ahead?
Yes, it's very informative talk, and Dr. Ravi was in favor of opening up volar through a volar approach whenever he requires a fixation through the volar side. And now we can see that arthroscopic fixation of the volar lunate fragment can be done. So these two techniques are available to tackle the peri-lunate fracture dislocations.
I have a question for Esther. How do you hold the reduction while you are pinning or while you are putting in an implant for the volar pole of the lunate, please?
So thank you very much for your questions. So after you reduce the fragment, actually after you reduce the fragment is not very loose again. And then you can use a probe to hook it and hold it in place while you open a wound over the volar side to put in the guide pin and the screw.
This is especially difficult because there are very strong ligament attachments on the volar side of the lunate. And do you find any difficulty reducing the entire lunate to the smaller fragment, or you reduce the smaller fragment towards the lunate?
We reduce the small fragment towards the big fragment. Initially, it's quite difficult because it's like a somersault. It's rotated like 180 degrees. So you need to have quite a strong force to reduce the small fragment back to its position.
All right. Thank you. Thank you.
Thank you.
Could I just make a brief comment? We published another paper in about 2018 where we looked at over 30 cases from the literature, and there's two types. One is like what Esther's just said, where you get this volar shearing fracture, and it's really a mid-carpal fracture dislocation. And the other one's a transverse fracture. It's a bit like if you pull the wrist all the way to the radial or ulnar side, and they really are quite different groups. It might be something worth looking up, that paper, but I think Esther's described beautifully some of the techniques to do this arthroscopically. And one thing you would have noticed is lots of associated fractures with this sort of injury. It's not just the lunate, it's really a peri-lunate injury. So I think Esther's shown that very nicely in how to do it arthroscopically.
Thank you.
Dr. Chow, one question. Do you find stabilizing the lunate through a radio lunate transfixation wire and then fixing the volar fragment there, so that there should be a stable major lunate part and then your fixation can be done?
Thank you for your questions. I think for the particular case that I've shown, there's because there's no significant SL injury, so there's no significant DC deformity in the two cases I've shown, so that I don't need to fix the lunate to the radius before I fix the fragment.
Thank you.
But in other cases, probably you need to fix the radial lunate in place before you do other fixations.
Thank you. Can we move on to the next
Good morning to all our viewers of this webinar. I'm here to present a case of an interesting pediatric wrist injury. I'm Dr. Anirban Chatterjee from Kolkata, India. So we had a 10-year-old boy who was right-hand dominant, presented with a fall from height while on vacation and injured his non-dominant wrist. He was initially evaluated by trauma series X-rays. There was no head, chest or abdominal injury, and this X-ray was available, which on the basis of which he was diagnosed to have a distal radius fracture and was immobilized in a above elbow back slap. He went on to complete his vacation and came down to his hometown after about 3 weeks, where a fresh X-ray was done, and here he was promptly referred on to our institute. So at 3 weeks, when we received him, we found that on his X-ray they showed a fascial injury of Salter-Harris type 2 of the distal radius, which was volarly displaced. The ulnar styloid had a fracture at the tip. The carpus, there was a transcaphoid peri-lunate dislocation. So at this time, when he is 3 weeks down the line, the treatment options we considered were whether to continue with conservative management or attempt a closed reduction or proceed with an open reduction and fixation. So what we did was we first tried an open closed reduction under anesthesia, and you can see that this was the C-arm picture, which clearly shows there was a type 2 Salter-Harris injury of the distal radius, which was volarly displaced. We proceeded to open reduction through a dorsal midline approach, as had been already described previously. The injury pattern was confirmed. Now, one of the challenges after reduction and achieving fixation for the scaphoid is that since this 10-year-old boy had the carpal bones, which were mainly cartilage covered, so the exact size of the screw needed to be confirmed, and here we utilized an arthrogram to help us achieve that more accurately. And here you can see the screw fixation from the dorsal aspect, and finally K-wire fixation of the rest of the carpal bones and the distal radius fracture. And afterward you can see that the Gilliula's line is restored. Post-op, we immobilized him in a slab for 4 weeks with suture removal at the end of 2 weeks. He disappeared after that and came back to us almost 3 years later, when he was around 13 years of age, and now you can see that he has fascial arrest in the distal radius, DRUJ which is disrupted, and there is shortening as well. But his functional evaluation showed that he had relatively poorer outcome as compared to what we would be expecting. On clinical examination, we found that he has valgus deformity in the wrist, and his pronosupination was restricted as expected. So at this point of time, how should we proceed? Well, should we address the fascial bar by doing a resection? Should we also do a corrective osteotomy, or just do a corrective radius osteotomy? Or should we just do a corticotomy and distract it so that we can get the length back? Or do a much simpler ulnar shortening procedure? What about the distal ulnar physis? Should we do a epiphysiodesis, or we should? And regarding the residual carpal malalignment, should we just observe it, accept the residual deformity, or should we do a complete redo of the same thing? So what we did was we first did a cuff resection of the distal ulna. We removed about 1.2 centimeter segment of the distal ulna, and you can see we fixed it with a plate, and now the ulnar variance was restored along with the DRUJ becoming congruent. Thereafter, we identified the distal ulnar physis, and we proceeded to do a distal ulnar screw fasciodesis like that. Thereafter, we looked at the residual radial inclination, and we did a radial osteotomy, did an open wedge type of an osteotomy, and filled it up with synthetic bone graft so that we could restore the distal radius alignment as well. So this was the final C-arm picture, and post-op we immobilized him again in a cast for about 4 weeks, and thereafter started with hand therapy. At the latest follow-up, about 8 months in the earlier part of this year, you can see this is the correction which could be achieved as compared to the pre-op clinical picture and the X-ray. And this is the clinical pictures at the end of 8 months, where you can see that the pronosupination has been well restored and his wrist flexion extension has also improved. On functional examination, we found that his hand function scores and everything had improved significantly, including his Mayo wrist score and the grip strength. When we did a literature review, we found that most of the literature was essentially case reports, and we could find about 8 or 9 such reports in the English language literature. So the learning that I had from this case, the peri-lunate fracture dislocations are quite uncommon when it is in children. They are often associated with distal radius fascial injury as is part of the greater arc of injuries. The visualization of the cartilage completely can be a challenge, and therefore an arthrogram is a useful adjunct in our armamentarium. The awareness to recognize this injury is lacking, and one should be looking out for that, have a high index of suspicion. Prompt reduction either by closed or open methods is needed, and a long follow-up is needed so that we can monitor the growth aspects of this and whether any growth in arrest or growth disturbance occurs. I thank you all for giving me a patient hearing and be open to taking questions. Thank you.
Thank you for excellent talk. Any questions for Dr. Anirban?
Anirban, in hindsight, the quick question. In hindsight, we saw the post-operative X-ray that there was still some dorsal angulation of the radius. So as the child grows towards puberty, I'm not sure how that will pan out. So do you think that a kind of a larger bone graft perhaps, or distraction histogenesis as you talked about? Yeah, tell me.
Well, since I had already done the physiodesis of the ulna, I don't presume there will be a lot of change in the radioulnar inclination with remaining growth. He's already 13. So yeah, you could say that I could further correct it a little more or overcorrect it. But we are still keeping him under watch, and that's the lesson learned from pediatric fractures, that you need to follow them up really long. You just can't say that till their growth is complete. For a boy, at least till 16, 17, we need to follow this child up so that there is no recurrence of the manus valgus deformity.
Thank you. Thank you.
Thank you. The next talk on mid-carpal instability and its relation to CIND by Dr. William Pienka II and Dr. David Lichman.
My name is Bill Pienka. I'm a hand surgeon in Fort Worth, Texas in the United States, and I'm happy to be here to present a historical review of mid-carpal instability on behalf of myself and my colleague, Dr. David Lichman. Mid-carpal instability has been known by multiple names over the years, and we'll provide a historical review today, as well as a history of the recognition of this disorder. Instability of the mid-carpal joint was first described in the mid-1930s in an asymptomatic female noted to have instability of her wrist ligaments. It wasn't until nearly 50 years later that the term mid-carpal instability was introduced by Dr. Lichman, and this was broken into intrinsic and extrinsic mid-carpal instability as a result of the etiology. Intrinsic mid-carpal instability was further subcategorized into palmar, dorsal, or combined types, and extrinsic or adaptive mid-carpal instability instability was reported as a result of distal radius malunion and more recently distal radius fractures. In 1984, White and Lewis introduced the term capital lunate instability pattern, or clip wrist, and they noted instability through the midcarpal joint that they attributed to laxity of the intrinsic wrist ligaments. Also in 1984, Johnson introduced the term chronic capital lunate instability and described instability through the midcarpal joint that they attributed to laxity of the intrinsic wrist ligaments as well. Patients had a painful wrist clunk and subluxation of the midcarpal joint in the dorsal direction, and they were treated with palmar radioscaphocapitate ligament reefing that corrected the midcarpal joint subluxation but resulted in loss of wrist extension. 13 years after the introduction of the term midcarpal instability, the Mayo Clinic group, Wright, Dobbins, and Linscheid, introduced the term carpal instability non-dissociative, which they subcategorized into SIND VC, or volar direction instability, SIND DC, or dorsal directed instability, or a combined type of carpal instability non-dissociative. They described 38 patients that they treated with either soft tissue reconstruction, joint leveling procedures, or midcarpal fusion, and had just 56% good or excellent outcome with no benefit of surgical management over non-surgical treatment. The introduction of the terminology non-dissociative was to differentiate this condition from the previously described dissociative carpal instabilities within the proximal row, namely scapholunate and lunotriquetral instability. This condition has been described using several different terminology over the last 40 to 50 years, all describing the same or similar pathology. Midcarpal instability and carpal instability non-dissociative, or SIND, have persisted as the commonly referred to names for this condition. The pathogenesis of midcarpal instability is incompetence of the ligaments that stabilize the midcarpal joint in the proximal row. This laxity may be the result of congenital etiologies, may be acquired, or as a result of trauma. Instability through the midcarpal joint in the dorsal direction appears to be a result of laxity of the arcuate ligament. Palmar midcarpal instability, or SIND VC, appears to be due to laxity of the dorsal radiotriquetral ligament, and there's some recent evidence that periscaphoid laxity, or STT joint involvement, may contribute as well. In palmar midcarpal instability, when the wrist is in neutral, there's flexion of the proximal carpal row with volar subluxation through the midcarpal joint and a VC appearance on the lateral X-ray. When the wrist is brought into ulnar deviation, the proximal row stays flexed until it reaches full ulnar deviation, where there's a sudden flip from flexion to extension instead of a normal gradual extension, and this is what causes an audible and often painful clunk. You can see here the midcarpal shift test being performed on one of my orthopedic residents can be positive in patients that have midcarpal instability. There is some controversy regarding what to call this condition though, as some authors and surgeons prefer the terminology SIND, while others prefer the term midcarpal instability. It's important to ask ourselves, is this condition truly non-dissociative? The true pathologic anatomy has not been fully verified, but we do know that acute disruptions of the dorsal radiotriquetral ligament will lead to palmar midcarpal instability. This will lead to a lack of synchronous action between the carpal rows. That ligament laxity can also be developmental or acquired and not truly dissociative. Further confusing the terminology are recent reports of traumatic non-dissociative carpal instability. And while we recognize that the proximal row is actually what's unstable, not just the midcarpal joint, the injured ligaments do cross both the radiocarpal and midcarpal joints, and they may be either lacerated, avulsed, or stretched. The terminology SIND was introduced initially to distinguish this entity from the proximal row dissociative lesions where the SL or LT ligaments are torn. But the ligaments responsible for stabilizing the midcarpal joint can be developmentally lax, stretched, or torn, and result in various degrees of subluxation or dislocation of the midcarpal joint. And lack of proper function of either the intrinsic or extrinsic stabilizing ligaments can therefore either be dissociative or non-dissociative depending on the magnitude of the ligament disruption. Dissociative and non-dissociative really have nothing to do with the location of the ligament pathology, simply describing the magnitude of the effect. In this table, we put the subcategories for midcarpal instability and SIND next to each other, including the primary pathology, surgical treatment options, and incidence, to show that these are really two terminologies for the same condition. In summary, I want to stress that midcarpal instability and SIND are terminology describing the same set of disorders, and what you call this condition is much less important than recognizing and treating it appropriately. We do believe, however, that we've been doing a field a disservice by continuing to perpetuate this confusion by referring to this condition by two names over the past 40 years. And while neither terminology is perfectly correct, we do prefer the term midcarpal instability and believe it to be the more anatomically correct terminology for this condition. I'd like to thank you for the opportunity to present a historical review of midcarpal instability and welcome any questions at my email seen on the screen.
Dr. Abhijeet.
I don't think there are any questions for him, right? He's not online, so we can move on to the next session a little bit. And Chetan, yeah. Thank you.
Thank you.
Thank you, Dr. Abhijeet. So our next session is on DRUJ instability, DRUJ arthritis, and wrist arthritis. Our first talk is by Dr. Wing Lim Si on clinical assessment criteria for DRUJ instability. Can we start?
Good afternoon. I'm Dr. Wing Lim Si from Hong Kong. It's my great honor to present clinical assessment criteria for DRUJ instability in this instructional course. DRUJ instability is very disabling, painful condition for the patient where his wrist is very painful upon rotation, which is a very important function of the wrist. You can see in this gentleman, even with full supination, the outlet is mobile, and then there's a click when turning from supination to neutral. And when I try to reduce it or even to exaggerate it, it causes even worse pain. You can see I try to pronate, it cannot, and also there's a rebound. So there is a partial irreducibility of this painful disability condition. And upon general anesthesia, you can see that there may be even more obvious marked disability, wobbling of the outer head along the radius in neutral, supination, and pronation. So the DRUJ instability has many causes, most common being the distal radius fracture malunion, or maybe some spring injury of the wrist, inflammatory arthritis, right, the rheumatoid arthritis, and the congenital adenomatous. Understanding the DRUJ anatomy is very important because you can see that the outer head arc is not comparable with the sigmoid arch. So there's gross instability just from the joint configuration alone. And we need the soft tissue stabilizer, be the static and the dynamic. The dynamic being the ECU tendon, and the static one, endogenous membrane, DRUJ capsule, and the most important, the TFCC. The TFCC is a three-dimensional structures spanning between the radius and the outer, and also supporting the outer side of the carpus. It's been defined by Toshi Nakamura that is the hammock structures. So it's a three-dimension providing stability in these three adjacent structures of the wrist. Among all these, the deep radial palmar ligaments will be the most important one because it seems to be more isometric during pronation and supination. There's also a superficial component out to the base and is more likely to provide additional stability and also a cause of the pain during rotation while the DRUJ was still quite reasonably stable. So when there's instability, there will usually the deep radial ligament is being torn, usually from the fovea. So we can see that this deep and superficial component will change in the tension upon pronation and supination. And so I have to analyze the pathology of instability in terms of dynamic and stable static stabilizers. And the diagnosis key is physical examination and imaging. Examination, we have to look for sign of systemic inflammatory arthritis, malalignment of the distal radius, and then usually it will diagnose if they have a painful piano key sign. And for more subtle cases, we have to perform the routine performance test, the press test, the pull test, and also the ECU subluxations, and also test for other diagnosis of mimicking the DRUJ instability, namely the midcarpal instability, LTP, and outlet impingement syndrome. So this is a piano key sign where even in pronation, which suppose the wrist is being locked, and then the patient still have a very mobile outer displays dorsally to coming to the radius, and then the pain will elicit if we try to exaggerate the deformity. And as I mentioned before, we have to examine every case carefully. And these are the DDX of the DRUJ instability. Examination of the establishment of the DRUJ instability is better to hold the carpus and the radius as a whole, which will increase the specificity of plotting the ulna. You can have a different degree of instability for this one. In the resting position is already dorsal subluxed. In other cases, it will be volar subluxed in the resting position, and then there will be translation demonstrated in all directions in the forearm rotation. The press-ups are seldom performed because it's quite painful. Basically, it's trying to lift up from the chair with a painful wrist, and it's not very specific. So the ECU subluxation has to be examined routinely so that it won't be mistaken as a cause of the pain. And then, in this case, you can see the patient have quite clinically quite unstable day, but it's not painful. He is still awake. So even though pronation supination is quite lax, and then the patient does not have a positive ECU synergy test. So the patient basically has a bit of ligament generalized laxity. You can see the fovea is not tender. And for the other cause of the pain, the LT, the PT is non-tender. LT is also non-tender. So finally, I do the test of autocarpal guidance. You can see it's jumping up from the couch. So this is outer impaction syndrome. So in assessment, the pain X-ray is standard, and we have to do a true lateral SPC view with the scaphoid pisiform and the capitate aligning in line, because a bit of pronation supination will make the assessment not accurate. And assessment being the dorsal distance of the outer head and the dorsal part of the radius is typical. If more than 60 millimeters will be diagnostic. Our salad has not shown to have a strong correlation with instability. Well, in further investigation, if it's more than 3 millimeters of displacement. CD assessment, we have different ways. The Binu and congruency method are easy to use, but it has a high false positive weight. Every method is a bit complicated, but it is more specific to diagnose a DRUJ in stability when in doubt. MR and alphagram and even with arthroscopy helps to establish the cause of the DRUJ instability rather than to establish the diagnosis of a DRUJ instability. So the big home message, ladies and gentlemen, knowledge of the DRUJ anatomy and kinematics is very important. We have to identify the etiology and also to look for the DDX of this DRUJ instability. The most obvious diagnostic sign will be the piano key sign, the positive DRUJ development test, and you have to exclude ECU, pathology, and also other DDX like outer impression syndrome, mid-carpal instability, and LT instability. CD and X-ray help to establish the doubtful cases. The alphagram and foxtrot help to locate the injury structures, but they have not helped to establish diagnosis of DRUJ instability. Thank you very much for your attention.
Thank you for the excellent presentation and beautiful clinical videos. There are no questions in the chat box. Is it okay if we move to next topic by Dr. Bharat Kadadi on arthroscopic radial styloidectomy and wafer procedure?
Chaitanya, can I ask a question?
Sure. Yes, please.
Yeah. Thanks, Limshe. Nice to see you again after a long time. Your assessment of the instability, is it kind of a single test, or is it a combination of everything? That is one thing. Is it always you would take it as significant only if it is painful, or just instability only is different compared to a painful instability? What is more significant?
Excuse me, can you repeat your question?
Can you hear me?
Yes, now, yes.
Yeah.
Yes, please.
Yeah, my question was whether the instability is a combination of all these tests and your radiological assessment also. Second one is it a painful instability is more significant, or just an instability with laxity? What we see is more significant compared to a patient having some amount of pain.
Yes, thank you. So thank you for your question, Annie, and thanks for your preparing such a quick conference. And yeah, I think the most important is we have to define whether it's a DRUJ instability or not. And usually we are concerned about the symptomatic painful instability. And I may not have clarified this in the short presentation well, but what I want to mention is that clinical is still most important the way to diagnose a DRUJ instability. That's why I stress on the development test and the piano key sign. In those subtle, more subtle instability that the patient may have a bilateral, a little bit less on one side, but a little bit more less on the symptomatic side, then we are not certain whether the symptoms is really due to that DRUJ instability or other causes. Then we may need to establish with radiological criteria like the most accurate with the CT using the epicenter method. So that's what I want to, that's how I assess the approaches DRUJ instability. You can find many people has a certain degree of instability, but if they are not symptomatic, then hopefully I will not go to further investigation with the CT, etc. Only if it is symptomatic, but not as very clear picture on the clinical key sign or gross instability that can be demonstrated on the development test, then I have to, and in the absence of the other ECU and LT in our infection problems, then I have to go proceed further for the CT to establish the DRUJ instability diagnosis.
Thank you so much.
Thank you very much.
Okay, our next talk is by Dr. Bharat Kadadi on arthroscopic radial stylorectomy and wafer procedure.
I'll be talking on arthroscopic radial stylorectomy, and then later we'll be talking on arthroscopic wafers procedure. So arthroscopic techniques for wrist arthritis, the radial stylorectomy and the proximal pole hamate excisions have been proven to be minimally invasive, with less morbidity, earlier motion, less recovery time, early return to work, and greater patient acceptance. So after Bernard in 1948 to describe open radial stylorectomy, it was Rowe in 1998, 50 years down the line, described arthroscopic radial stylorectomy. So indications are mainly pain due to radioscaphoid impingement, a slack wrist or a snack wrist, complications of distal radius fractures, malunion or non-union, and also patient is early arthritis, rheumatoid arthritis or osteoarthritis. Contraindications being, of course, medical contraindications. Patient who has panarthritis, doing only a radial stylorectomy will not work. Patient who wants only one operation. And beware of patients' workman's compensation, and those patients were operated multiple times. So when you think about size of the resection, when you resect 3 mm, you preserve the styloscopic capitated ligament. When you resect 6 mm, you knock off the RSC ligament. But when you resect 10 mm, you go into the radial lunate ligament. So it was Nakamura who described that found ligament laxity and significant palmar and ulnar carpal displacement after 6 to 10 mm of radial stylorectomies, and that therefore he recommended limiting the stylorectomy to 3 to 4 mm. The right wrist, focusing on the styloscaphoid area, and our Vyas portal is the 3-4 portal, and the working portal is 1-2 portal. It's important to have a good set of your burrs, 2.5 and 2.9, and also 3.5 burrs. Here is a patient with the styloscaphoid impingement due to non-union, and then so early arthritis patient with the styloscaphoid impingement. What you do is a synovectomy in the styloscaphoid region. And then you clear the area of the radial styloid. You can see there's some cartilage erosion also there due to early arthritis. Once you clear the area of the radial styloid. That's the outside view. On the right wrist, you have the working and Weaver's portal. And then you pass in the smaller burr first, the 2.9 millimeter burr, the smooth shaving motion from the anterior to the posterior aspect. And then you might also need a large burr to resect the whole of the radial styloid. And as I told you, limit the radial styloid to not more than 3 to 4 millimeter. And always use a probe to assess the amount of resection. As you can see, the large burr is abutting on the radial styloid and smooth swaying motion. Anterior and posterior aspect of the radial styloid is also a good balance of the suction so that you take out all the resected bone. And you can see the pre-op and post-op pictures. Also, you'll be able to appreciate the video, the intra-op CM video where the ulnar and radial deviation will be able to see the no more impingement. Another patient with the radius scaphoid impingement due to a malluminated distal radius after radial styloidectomy, and then no impingement or radial deviation. You can see here. So X-ray before and after the resection is or a CM is during and the surgery is very important. So immediate mobilization after radial styloidectomy alone. Splinting for pain and hemorrhagosis maybe 2 to 3 days. It's a minimally invasive surgery, early rehab, palliative surgery. The best patient is a SNAC 1 or a SNAC 2 wrist or a SNAC. A good strength, a patient with a good strength and mobility, a patient with a painful wrist. PRC and partial wrist arthritis can always be done at a later date. Coming to the Wafers procedure, it's partial distal ulnar resection. Distal 2 to 4 millimeter of ulnar is resected, preserving the distal radioulnar joint, ulnar styloid, and the ligaments attached to it. So shortening of the ulnar from neutral to 2.5 millimeter ulnar variance has been shown to decrease the pressure between the ulnar and the lunate by 75%. The ulnar impaction syndrome leading to tears and the painful cystic lesions of the lunate and triquetrum are the indications. Symptomatic ulnar positive, the variance of 2 to 4 millimeter. The contraindications being greater than 4 millimeter of ulnar positive variance, where you would prefer to do a ulnar shorting osteotomy, DRJ degenerative arthritis, or DRJ instability, and couple instability being the contraindications. Here you can see between 2 to 4 millimeter of ulnar positive. You can also see corresponding changes in the lunate. And when you rotate the ulnar, which is already a perforation tear secondary to ulnar positive variance. So what you initially do is basically a debridement of the central perforation tear to make your area clear. So you have a 3/4 Weaver's portal and the 6R as the working portal to a proper debridement of the perforation tear to reach the head of the ulnar head. And then you go ahead and use a burr. Initially start off with the 2.9 burr, go through the perforation, 6R working portal, and make sure you do a adequate resection of the ulnar head. And then you're able to use a probe and assess the amount of resection which is done. And as I told you, the resection should be limited to 2 to 4 millimeters and not more than 4 millimeters. And you can get reasonably good results follow-up. As you can see, this patient in 3 months follow-up. So a comparison of combined arthroscopic debridement and arthroscopic wafer versus arthroscopic debridement and ulnar shorting osteotomy, you can see marginally it's better. The wafer procedure is marginally better in terms of restoration and function, with a fewer secondary procedures like tendinitis when compared to ulnar shorting osteotomy. Thank you, and my acknowledgements to the APWA whole team. Thank you, one and all.
Thank you, Bharat, for that talk. Any questions?
Hello, this is PC. May I ask this question? Yes, thank you very much. I think very good illustration of how useful is the technique. Just I want to ask if for the slack wrist management of the, do you also treat the scaphoid non-union at the same time, or you just resect the radial styloid as for the treatment? How do you decide when you just perform the styloidectomy and when we also perform the scaphoid reconstruction?
Yeah.
The arthritis is limited to the styloscaphoid region. So it's always good to do a radial stylorectomy and then go in for a fixation of the scaphoid, because it prevents the progression of the arthritis. If you fix the scaphoid, it's always good. If it's a snag race, it's always good to fix the scaphoid and do a radial stylorectomy at the same time.
Sorry, can you clarify? You also resect the scaphoid, or you reconstruct?
Yes. If the patient presents early, say within 1 year or 2 years of non-union with a styloscaphoid impingement, I would do both. I would do a radial stylorectomy. At the same time, I would fix the scaphoid. When the patient, So if the patient presents very late, maybe 5 years down the line with the early arthritis, I wouldn't go and do because I want to give some temporary relief. I do a radial stylorectomy, wait for some time, give 1 or 2 years time when he has pain relief, and then come back and do a salvage procedure.
Yeah, okay, yeah. Because I think sometimes it may also consider a distal scaphoidectomy for very chronic scaphoid non-union, but still maintain a very good proximal scaphoid status. I think in addition to radial styloidectomy, a distal scaphoidectomy can also perform simultaneously. But of course, there would be some sort of salvage procedure rather than restorative procedure. But I think may be useful for some less demanding patient who has mainly concerns about the pain and not so functional demand on the wrist. Yeah, just to share some experience. So
thank you so much, PC.
So, Dr. Ho, is there any kind of a criteria for when you do the distal scaphoidectomy in terms of the fragment size itself?
Well, mainly I think it's good for those distal scaphoid non-union situation where you still maintain a large proximal scaphoid which is non-arthritic. So I think sometimes the distal scaphoid would be very arthritic with osteophyte formation, and that is the major source of pain because there's a conflict between the distal scaphoid fragment and the styloid, which create the source of pain. And if the patient is mainly concerned about the pain and do not want to have a very complicated reconstruction situation, or don't want to have a complicated salvage like the selective procedure, I think that will be some sort of buy time status, because it can be, if for example, under our hand, we just do it under local anesthesia in the outpatient setting. So very easy, maybe 20 minutes work, you can remove the scaphoid and the patient can do the rehabilitation quickly. But of course, I will warn the patient if because just a simple distal scaphoidectomy may run the risk of further collapsing the mid-carpal joint and produce further DC deformity, and that may actually induce pain later on. So I will warn the patient that if the patient's symptoms develop later, I may actually need to go to do a full set of scaphoidectomy with the mid-carpal fusion. Like in our hand, we also do the capital-lunate fusion. So that will something additional notch to the patient when I offer the distal scaphoidectomy for patient as a symptomatic relief surgery.
Thank you, Dr. Ho. We'll go to the next talk by Amanda. Total wrist arthroplasty in Hong Kong, experience of past 18 years.
Hello everyone, my topic for today is total wrist arthroplasty in Hong Kong, our experience in the past 18 years. I'll be representing my seniors and colleagues, and we are from the New Territories East Cluster in Hong Kong. So late-stage and symptomatic wrist destruction pathologies are often treated with wrist arthrodesis. It's the ultimate salvage procedure.
Abhijeet, can the volume of the audio be raised by any way?
Unfortunately, that's the only maximum volume in the video itself. Is Dr. Amanda here online?
Yeah, I saw her logged in.
Yeah, hi.
I'll just try. Amanda, hi. Unfortunately, the volume is not very good in your video.
You want me to present the share the PowerPoint on?
Do you have it?
Yeah, I have it. I just need to open it.
Oh, just wonderful. That'll be great, I guess, because the audio is not good at all.
Is the audio okay from here? Can you?
Yeah. It's okay from your side. Thank you.
I have the PowerPoint here.
Perfect. So go ahead and share it.
Figure out how to share screen. Sorry.
Can Rishi, can you please make Dr. Amanda co-host? and allow her to share the screen, please. Thank you. Yeah.
Can you see my PowerPoint?
Yes.
Yes.
Hi. So I'll be presenting on the total risk arthroplasty in Hong Kong, our experience in the past 18 years, and I'll be representing my seniors and colleagues from the New Territories East Cluster. So on the background, so the late stage and symptomatic wrist destruction pathologies are often treated with wrist fusion. It's the ultimate salvage procedure because it provides reliable pain relief, reliable function, and it's technically straightforward, but it leads to a loss of the wrist motion and may not be acceptable to some patients. So the total wrist arthroplasty was first introduced in the 1890 by the German surgeons, and subsequently Swanson popularized it in the 1960s by introducing a flexible hinge one-piece silicone implant as a dynamic spacer. So it provided good initial pain relief and functional range of motion, but over time there was a high failure rate, progressive deformity, and implant fracture as well. So over the years, there are many different implant designs. So the second generation implants utilized ball and socket joints, but they had a problem of soft tissue balancing. And the third generation implants had ellipsoidal or toroidal carpal components to better replicate the natural wrist motion. And they utilized cement fixation as well, but they had problems of carpal component loosening. And the fourth generation implants that we use today aim to reduce the rates of design-related difficulties and complications, improve the biomechanics, minimize bone resection, as well as the carpal component loosening. And the newer designs have ellipsoidal articulations. They use materials to promote osseous ingrowth and have locking and fixed angled screws to secure the distal component better. So for total wrist replacement, is quite uncommon in the Asia Pacific. We have no published outcomes of the total wrist replacement in Hong Kong so far, and it's not often performed or reported in the Asia Pacific as a whole. So there are some concerns with this procedure. So mainly the survivorship concerns. It's technically challenging, especially if the bone stock is severely compromised, and salvage procedures can be quite difficult as well. So in our experience, over the past 18 years, we had 10 patients and they were followed up at a mean follow-up period of 70.3 months. We operated on 12 wrists and we had 9 female and 1 male patient. And the mean age on operation is 59.2 years old. We had 9 cases of rheumatoid arthritis and 3 cases of psoriatic arthritis. The first 4 cases, we used the biaxial total wrist replacement implant. And then subsequently, we used the remotion implant in 7 cases and the universal 2 implant in 1 case. So for the outcomes, there's no significant improvement in the post-op range of motion. Most patients gained the extension range, but they lost the flexion range. There was significant improvement in the pain score, and as well as in the performance score, namely the DASH score and the PRWE score. The mean grip strength also improved from a mean of 7.3 kg to 9.9 kg. For complications, we had 1 case of metallosis in a patient who had the universal 2 implant inserted, and she required conversion to a total wrist fusion later on. We also had 2 cases of loosening and 1 of a superficial wound infection that was treated with surgical debridement as well as antibiotics alone. So we compared our outcome with that of larger studies. So this one involved 215 wrists. They did the remotion total wrist arthroplasty in all of them. And they, like our study, they found improvement in the pain score and DASH score. Also no significant difference in the post-op range of motion, improvement in the grip strength, and 11 of their patients underwent revision into a fusion or a revision total wrist replacement. So the accumulated survivorship of the remotion wrist replacement implant that we use most commonly now is about 80% at 10 to 12 years. So here are several cases to illustrate the post-op functional outcome for our cases. So this is the first case that we did in Hong Kong. It's a 68-year-old lady with rheumatoid arthritis complaining of bilateral wrist pain and stiffness. So as you can see, there's a severe gross destruction of the wrist joint. And we used the biaxial replacement, biaxial implant back in 2004. And the intra-op range of motion, as you can see, is quite satisfactory. And at post-op 22 months, as well as post-op 18 months, so she had bilateral wrist replacement done. You can see that the alignment is still well maintained and it's also quite well fixed as well. The second case is a patient with rheumatoid arthritis as well. She had a right wrist biaxial total wrist replacement done back in 2004. And after the operation, this is 12 years post-op. You can see that the range of motion is still fairly satisfactory. So 30 degrees extension, 16 degrees flexion, some 75 degrees pronation, 90 degrees supination, adequate grip and pinch strength, and the wrist score, pain score, PRWE score, and DASH score is overall quite satisfactory. As you can see from the video, she also has a pretty good range of motion and function here. Yeah. So this is the third case. This is a patient with psoriatic arthropathy, a 55-year-old lady. Intra-op, you can see how stiff the wrist is, and there's a gross joint destruction on the X-ray. We used the remotion total wrist replacement for this patient, and at post-op 29 months, she still enjoyed quite a good range of motion, and the X-ray alignment was still overall maintained. And another case of a rheumatoid arthritis in a 68-year-old lady. She strongly refused fusion and really requested for a motion-preserving surgery. So we had to wait till we were able to obtain the remotion implant for her. And at post-op 17 weeks, you can see that the range of motion for her wrist is also quite satisfactory for this patient. Yeah. So the last patient is the youngest in our series. She's a 33-year-old lady with bilateral wrist involvement for rheumatoid arthritis, quite severe involvement due to a delayed seeking of medical treatment. And we did the remotion total wrist replacement for her. And you can also see a part of the implant. So this is the radial component with the PE insert as well as the carpal component there. And this is the post-op outcome at about 10 weeks. And she is able to enjoy a pain-free some motion of the wrist, and I was quite satisfied with the function so far. Yeah. So this is just several cases to illustrate our experience. And overall, we find that we were able to have a good patient satisfaction with the total wrist replacement despite the limited range of motion, and some also had to undergo additional operations in the same setting. There is, of course, some limitations. We have a pretty small caseload due to few referrals from rheumatologists, successful arthroscopic synovectomy for the advanced rheumatoid arthritis, and also generally a lack of commercial support and interest. And we hope that this will change in the future. So thank you for your time, and thanks for listening. I welcome any questions. Yeah.
Thank you, Amanda, for that wonderful lecture. Any questions from the audience?
I have a question for Amanda. Do you have any experience or any information about ceramic on ceramic bearing for wrist joint? And what are the advantages of disadvantages of a ceramic on ceramic bearing for the wrist joint?
Okay. Sorry, I don't have any experience for the ceramic on ceramic implants, and I have not really read up or studied up on it. But I think in general for ceramic on ceramic, we worry about ceramic fractures as one of the complications perhaps. And it's also quite difficult to convert to any other implant afterwards if that's the case. But I'm not sure if anybody has any experience on that as well. So.
Thank you.
Amanda, what is the main reason for that loss of flexion, almost 50 degrees loss of flexion? What do you think is the main reason for that?
Well, that's a pretty good question. I'm not too sure in our cases why this is the case. I think one of the potential reasons is maybe due to the sizing, because when the sizes available in the commercial implants may be a bit too large for our Asian population. We tend to use the S size and the XS sizes for these patients. So I think maybe to some extent it may cause overstuffing of the joint, which may also limit the range for our patients. But I'm not too sure. This may be one of the potential reasons.
Well, this is PC. I think when the case was done by me, I think mainly the reason possibly because the surgical approach is still dorsal approach. And it's really quite extensive dissection. You really go from all the way from the first dorsal compartment all the way to the sixth compartment in order to expose the entire wrist. And there's still quite a lot of stuff to work. So I think that is maybe the major reason why the patient may lose some of the fraction. But having removed the source of the pain, the conflict of the joints, the patient will enjoy more extension because most of the time, preoperatively, the pain is actually due to the extension because of the incongruity of the joint. But when you reduce the incongruency, you actually much enjoy. So for patients, it's still very useful because you know that the extension is probably more useful in the daily activity. And so that's why most of the patients are still very satisfied with the range of motion, despite the overall range of motion does not get much improvement, but the arc of motion is actually changed a bit and is go more towards the functional side. I think it's also consistent with the other major series that actually the range of motion, unfortunately, in total wrist replacement, usually cannot be altered. If the patient preoperatively has already got a stiff wrist, usually the operation, after the operation, the similar range of motion will remain. So that's why I think for the case indication, the best case indicator for total wrist replacement is those patients who has a painful wrist but still maintain a reasonable range of motion. Those patients will hate to get fusion because it would make much more limitation. And this patient will probably best benefit from the total wrist replacement.
Thank you, Dr. PC. I think that's very important in terms of patient selection for these kind of procedures. Dr. Amanda, there's one question. Is there any early failure of processes, and can you tell us how to avoid this complication? This is from the chat box there.
One of the cases who have the metallosis, she presented quite early. So I think this is something that we couldn't really avoid because we won't know that she would have this complication in the first place. For the cases of loosening, I think one of the surgical tips that we need to be aware of is a proper alignment of the implant, proper centering of the implant along the radial axis. And this can be achieved by ensuring a proper radial tilting, adequate resection of the distal radius to seat the implant better. So for the remotion implant that we use, we usually recommend, they recommend no more than 10 degrees of radial tilting. So we need to make sure that we have that to properly seat it in the center of the distal radius instead of it being malaligned. Yeah. So this is one of the.
Thank you so much for that. We'll move on to the next talk, the last one in this session, custom-made metal 3D printed total wrist arthroplasty, design rationale and case introduction by Shailesh.
Dear my friends, I'm Shailesh from Beijing Chetan Hospital, and it's my great honor to have a chance to introduce our experiences using custom-made metal 3D printed total wrist arthroplasty. This time I will introduce design rationale and some cases in brief. As you know, the wrist arthroplasty has the same long history with the hip and knee arthroplasty. However, long-term outcomes couldn't compare with those of hip and knee replacement. And there are no total wrist arthroplasty products on the market of China at present. On the other hand, the metal 3D printed implants and custom-made products have become a hot topic of research and application in the field of orthopedics in China in the past decade. Inspired by all these above works, we designed a total wrist arthroplasty using a metal 3D printed technique. This arthroplasty was designed based on the fourth generation of total wrist arthroplasty. It was composed by 3 parts, and the proximal one is a price-fitted radial component, which was printed by cobalt chrome molybdenum alloy using a one-piece printing technique. And the distal one is a copper plate. Also, it has a trabecular titanium structure, which is printed also by 3D printed technique. And there is a fixed central peg and 2 variable angle locking screws on the titanium copper plate, which could create bone ingrowth and stability. And the middle part is a copper ball, which is made of ultra-high molecular weight polyethylene with good biocompatibility and wear resistance. The range of motion of these processes, the palmar flexion and dorsal extension nearly 90 degrees, and radial ulnar deviation at 30 degrees. It could satisfy in most circumstances. The case 1 is a 46-year-old female, has a history of distal radius fracture more than 20 years. Her main complaint are pain and stiffness, which was aggravated in the past 2 years. We use a longitudinal incision at the dorsal side of the wrist joint. We incise the extensor retinaculum and periosteum, ligaments, and capsular in a longitudinal incision, and wrist soft flap to the radial side and ulnar side, and then performed proximal carpectomy. And for the purpose of achieving the best price-fit effect, so the robot-assisted technical was used always. We also compare the preoperative plan and post-operative data using the computer-assisted technical. We hope to find whether the long-term treatment outcome could be influenced by these differences or not. And 7 months after operation, the dorsal flexion, the palmar flexion, and the X-ray demonstration are good. Case 2 is a 21-year-old female, and the diagnosis is rheumatoid arthritis involved in right wrist. 6 months after operation, you can see the price fit of the process is very good, and the supination, pronation, dorsal flexion, and palmar flexion, dorsal extension, and palmar flexion of wrist joint was all acceptable. Case 3 is a 41-year-old female, RA involved in both sides, and 6 months after operation, you can see the bone ingrowth has been occurred already, and the price fit was very good. We also use the total wrist arthroplasty to reconstruct the wrist joint after tumor resection. This is a 26-year-old male, and because of a giant-sized tumor of the left distal radius, he received the tumor carotid and bone graft and plate fixation in the other hospital. Unfortunately, 1 month after operation, the wrist collapse and dislocation occurred, and no any useful motion in wrist joint, and felt severe pain simultaneously. Because this young guy refused any other alternative methods, such as the free vascularized fibular head transfer, so we designed this kind of total wrist arthroplasty for him. 6 months after operation, the price fit and the position of the prosthesis was good. If severe bone loss or osteoporosis existed, a MoTech-like prosthesis was designed and printed. This is a 28-year-old female, and RA in both sides. We performed operation to the right side. We're using a long curve incision to perform this procedure and the direct procedure simultaneously. Also, the orthopedic robot-assisted technical was utilized. And because the epidemic limitation, she couldn't go back to receive the follow-up. However, she contacted with us from the internet. She's satisfied with the treatment outcome and hoped we can perform the similar procedure to the other side. Case 2 is a 35-year-old female. You can see both sides wrist joint, severe deformity, and also some deformity occurred in small joints of the hand. From the X-ray, we can read that the bone loss and the severe dislocation occurred in both sides. 6 months after operation, and no any pain, and also the hand function were improved more or less. The patient herself satisfied with the outcome, even though it seems not so much motion was restored after the reconstruction. And discussion. As you know, the medical 3D printing was once an ambitious pipe dream. However, time and investment made it real. And nowadays, applications vary from anatomical models, mainly intended for surgical planning, to surgical guides and implants. There are, of course, any advantages of the 3D printed technical compared with the traditional subtractive manufacturing technical. And a bone ingrowth from metal 3D printed tubercular structure might resolve the problem of loosening, which is prone to be occurred after total wrist arthroplasty. Of course, the 3D printed technical have some disadvantages, such as manufacturing speed is not so fast. The duration is always need at least 1 month, and the cost is higher than the traditional products. And as you know, the wrist joint perhaps the most complicated synovial joints in the whole body. So perfect design is still very important. And of course, long-term observation is indispensable. So because finally I want to say, because epidemic limitation, I couldn't go India for this APWA annual meeting. I hope in the future I can go India and to enjoy the serenity of the Ganges River and the magnificence of Taj Mahal and taste the culture and unique food of India. Thank you. Thank you all.
Thank you, Professor Shailesh, for that wonderful talk. Are you online? We couldn't see him online. Couple of questions for him.
He's not online, I believe.
He's not online. Anybody else would give any inputs on the 3D printed processes or any kind of implants in terms of their usage, in terms of the regulations which we need to follow because they're implanted inside, and the manufacture itself in terms of a sterile kind of implant being produced? Any experience on this? Dr. Jeff, you have any kind of experience on the 3D printed implants?
No, I have none, and I haven't done many total wrist replacements. There's something that I tend to avoid if I can, and look for alternatives. So I don't have much experience. I do know that revising them can be difficult, and it can take 1 to 3 operations to get them to unite because there's such a big defect. That's my only experience.
Because I think the oncologists use it a lot to have customized kind of implants whenever they do surgical excisions of big tumors. But orthopedic wise, I think it's still in early stages. Right. I think since Dr. Shailesh is not online, we would stop this session, the discussion on this. We'll go on to the next and the last session on ECU and Lunate pathologies. I request Bharat and Prashant to take over for the moderation.
Thank you, Dr. Anil. Welcome my co-chair, Dr. Prashant. We're going on to the last session, Instructional Course Lecture 6, last and interesting session. So can I invite Jeff Acker to speak on ECU test, please? Thank you.
Extensor carpal maris tears. 42% of the population have what is considered to be an unstable ECU tendon. It's a normal anatomical variation. In these patients, it's the same on the other side and asymptomatic. It becomes significant only if it's asymmetric and painful. The symptoms are mechanical ulnar-sided wrist pain. On pronation and supination, there may or may not be a snap or a click. It's not always this easy to detect. You need an ultrasound, and I believe it's very important that as hand surgeons we evolved using high resolution ultrasound, and it becomes part of our normal examination of the wrist. And here you can see an abnormal ECU tendon. It's separating into its longitudinal fascicles, moving asynchronously around the ulnar styloid and snapping backwards and forwards, and you can actually feel that under the probe. You can push down on a longitudinal failed ECU tendon and it will squish under your thumb. It's an interesting feeling. You can feel it disperse and you can almost hear it in your fingers. And in this case you can see it's grossly separated. It's moving in 2 distinct parts on the ultrasound, and when you feel it under the ultrasound probe, you can feel the click. You can't feel it clinically, but when you've got the pressure on it with a probe, not only can you see it, but you can feel the click. This is what it looks like when it's failed longitudinally and is separating on an MRI scan. And here it is opened up, so you can correlate what it looks like with the MRI features and the ultrasound. There's an excellent paper that talks about the anatomy of the ECU sheath, and it points out the importance of the distal portion of the sheath. And this is what it looks like anatomically. You can see the ECU, the sheath, and the importance of the distal sheath and the extensor retinaculum and its confluence. The bone morphology doesn't make a difference. You don't need to make a longitudinal trough or groove to stabilize this, as it's simply not there anatomically. So what happens with the ECU tendons when they fail? They fail in cross-section. They're strong longitudinally, but they're weak transversely, and the tendons separate, especially with this movement that we've been talking about. So over 3 years, we have dealt with 9 ECU tendons that have failed requiring repair. Now we need to put this in a context. Over this period of time, I've done more than 800 arthroscopies, and I tend to operate on approximately 10 to 15% of the patients that I see. So this is rare. Now the other thing that was obvious is that 4 of these 9 cases had triangular fibrocartilage tears. 1 had a scapholunate instability. 3 had triangular fibrocartilage tears and scapholunate instability. And only 1 of the 9 cases was isolated pathology in the ECU tendon. So I've extended this diagram of Greg Baines on global injuries to the wrist and included the ECU tendon, because it's part of the global spectrum of injury to the wrist. And here you can see a normal foveal insertion using dry arthroscopy, and you can see the tear is extended into the ECU sheath. And not only that, you can see the ECU tendon is separated into longitudinal fascicles. That's a normal foveal insertion of the triangular fibrocartilage. So let's talk about the surgical repair, or how you deal with these when these are symptomatic and painful. And I've referred to this as cross-sectional separation of the ECU, which extends into noodle tendon, where the fascicles just look like a batch of noodles, and then it goes on to complete rupture. So here you can see cross-sectional failure of the ECU tendon, which is symptomatic, moving abnormally on ultrasound. It's been longitudinally repaired with 3-O-ethibond. The next thing is to make sure the distal ostia of the sheath and extensor retinaculum is stable. You need to repair this with a local tissue or retinacular flap. I haven't had to use a tendon graft, but one day I might need to do that. You want to restore or maintain the normal gliding motion from proximal to distal, but also from dorsal to palmar, which is the normal physiological movement. You want a smooth gliding surface. You don't want it gliding on rough, irregular bone. And you want excellent blood supply for tendon healing. So how do we solve this problem? Well, in this series, we've used a posterior interosseous artery flap or a posterior interosseous artery perforator flap. Occasionally, the perforators come out between extensor digiti minimi and EDC, so you've got to be careful. That's what makes it unreliable in some people's hands. You turn it around, you put the vascular pedicle dorsally so it's not compressed, and create a beautiful, smooth, sliding sheath for the extensor retinaculum. Then reattach it distally to the extensor retinaculum and the stable distal ostia of the sheath, and then reattach the sheath to the dorsal tissue adjacent to the ulnar ridge of the extensor digiti minimi sheath. Then repair the extensor retinaculum anatomically. And then what you have is you have a normal extensor retinaculum, a beautiful smooth gliding sheath which is stable. The sheath is stable distally. Now as we move on, they become more and more longitudinally separated until they rupture. And here we have a chronic rupture of the ECU tendon, and that's neotendon. Didn't have a palmaris longus, so I've done a turn down graft, and I'm going to include that with the neotendon. And when you're using a vascularized fascial fat graft with neotendon, the neotendon will go on to regenerate into tendon. And I'm elevating a fascial fat flap, a thin layer of fat over the top of it. It needs to be wide enough to form a nice smooth tunnel around the ECU tendon and graft. There's a distal modified pulvitaft, a proximal modified repair. And here you can see the posterior interosseous artery flap being wound around the graft and the repairs to form a smooth vascular gliding surface. I haven't shown you, but distally I've used a retinacular flap elevated from radial to ulnar to repair the distal ostia to make sure that it's stable. So what are our outcomes over 3 years in these 9 cases? Well, the outcomes were an average of 8 months after surgery, ranging from 6 to 12 months. The DASH went from 30 to 11, PRWE 41 to 15, VAS at rest 1.4 to 0.3, VAS on use 7.2 to 2.8. Our gross script went from 28 kilograms to 32 kilograms. Our force plate was reduced, and I believe this represents or is a reflection of the scapholunate instability, where we had 4 cases, and they tend to have a residual problem with force plates. Supination strength went from 67 kilograms to 100 kilograms. That's excellent. Pronation again excellent, 40 kilograms to 75 kilograms. There were no cases of recurrent instability or problems with the ECU. There were no revisions. So in conclusion, ECU instability is not pathological unless it's asymmetrical and painful. ECU tears run a spectrum from cross-sectional separation, noodle tendon to complete rupture. ECU tears are rare, 1% in our entire caseload of wrist arthroscopies. It's nearly always part of a global injury to the wrist. We've used a retrograde posterior interosseous artery fascial flap or perforator flap to create a smooth gliding surface, vascular tissue to promote healing in the tendon. Theoretically, there's living fat, which may increase the potential for regeneration, and we've been able to maintain the normal anatomical movement of the tendon. Thank you.
Thank you, Jeff. That was a very interesting and informative and a lucid presentation of a rare problem. Are there any questions in the chat box? Praveen has a question. Do you need to deepen the ECU groove anytime when you?
No. If you look at the anatomy, the groove isn't important. It's the strength of the soft tissue at the distal ostia, the 6th extensor compartment, and the tissue distal to it. And I started all the tricks, deepening grooves, anchors, but this is what I found to be the most useful, and it addresses the pathology. Now, there's Correa's just recently reported on endoscopic using the arthroscope endoscopically assist or view the ECU tendon. That's really quite easy to do, and also use the technique to repair. But this is biological, looking at the vascularity and recreating the gliding. I actually, it's an important tendon. Some of my colleagues say, why do you worry? Why don't you just cut it? But I find that somewhat offensive. I'd like to try and get all the muscles together and the tendons working and rehabilitate the wrist arth sports if possible. But that's always an option you can give to patients. Leave it alone.
Thank you. Was the etiology similar in all 9 patients? The etiology,
Sorry?
the etiology of the tear.
Oh, in this series, it was associated with instability and separation and gradually tearing out and then failing. But there are other problems that cause pain in that area, like tenovaginitis tenosans, or a tight tunnel, or restriction distally. So there's many different kinds of problems that you can have in this area, and it did highlight the importance that it's part of a global injury, and also the importance to note that instability by itself is not pathological. You need to look at the other side. And the other thing that I found, which was invaluable, is we have a very high resolution ultrasound, and it's important to check these patients with the ultrasound, because you often can't find the pathology. You don't realize that it's separating. So all these tendons were separating longitudinally on the ultrasound.
PC has a question, Jeff. ECU tendinitis is very common MRI finding. Do we think we may need to do more proactively on ECU problem to prevent the rupture as a terminal sequelae of this
I don't, the MRI.
Tendinosis, you mean.
Yeah. Thank you, PC. Thank you for the question. The MRI is useful, but you need to interpret it yourself, and by itself, without the clinical examination, as PC's taught us, it's just so important to listen to people and examine them thoroughly. The MRI helps, but most of the time you made the diagnosis without the MRI. You've made it by clinical assessment and on the ultrasound, and it's just nice to see it on the MRI. I mean, the MRI, it's a bit like music. It's the space between the music that counts, and often a lot of we see on the MRI is it gets rid of other problems, it excludes other problems, and I only find it useful in that way.
Thank you, Jeff. Thanks so much. There are no questions, no other questions. We move on to the next talk by Professor Methola, Christoph Methola, on arthroscopic bone grafting in lunate lesions.
My dear friend, I would like to share with you the very easy technique to treat the complicated problem of lunate ganglion. The lunate bone ganglion, the diagnosis is done by the chronic painful wrist with no history of trauma, plus or less a decreased range of motion and strength. And you need X-ray, CT scan, MRI. Sometimes on the X-ray it's complicated to see. Sometimes it's a little more easy. And classically, the ganglion is in the middle of lunate or in the front of the lunate, depending on cases. And you see that there is a rupture of the wall in scapholunate joint. The scintigraphy could be helpful, and the indication of treatment is only in case of painful ganglion. It means a symptomatic ganglion, and the pain often occurs when the ganglion breaks into the scapholunate space. The treatment is very simple. You know that the open surgery is very complicated, but for arthroscopically, it's very simple. We use a local regional anesthesia. Tourniquet is outpatient basis. The graft is bursted from the distal ridges, and we use only a 1, 2, and a 3, 4 portals. The approach is through the proximal portion of the anterior ligament, because we know now that there is not only arch ligamentous from the scapholunate, but 2 ligaments, a dorsal and a volar ligament, and the proximal part is useless, is not important, and we can pass through without any problem with a needle like that. And we found easily arthroscopically the bone. You have to curate the bone and to remove all the tissue inside the bone. The harvesting of the graft, we use the Jamshidi trocar. Is a very simple procedure. We perform a small approach on the lateral aspect of the radius, taking care, of course, of the radial nerve, and we go directly with the Jamshidi trocar inside the bone. We remove the graft easily with this technique. It's not a problem at all, very simple. Then after that, we put the trocar inside the ganglion, and we push the graft inside in order to fill completely the ganglion. You see in this small video the principle of the technique, the entrance by the 1, 2 portal for the camera, and with the needle we use the 3, 4 portal. We check and we find the lunate ganglion. We can pass through this proximal portion without any problem, and using a shaver and a curette. I use the wet technique at this period in order to clean correctly, but at the moment to put the graft inside, of course, is better with a dry technique. You see the Jamshidi, and we push the ganglion inside we put the graft, inside the ganglion in order to fill it completely with the graft. It's very simple, very easy. Two very small approach. It's not necessary to close it. And you see here. Our series is 23 patients. We have no importance of repetition between male and male, right or left, but a majority in dominant hands. We don't have a majority of sedentaries because I worked in Paris. So the mean age is 33 years old. The average follow-up is 3 years. You see this case, a right-handed male. You see the beautiful ganglion, dorsally located, and after 4 years, he had the full range of motion, soft minor soreness in the wrist, but no pain, and very happy with the technique. The time to union is between 5 to 8 weeks. We don't have any non-union. We have increasing in range of motion, grip strength, and good result on dash and pain, of course. This case is a female nurse, you see, 25 years old, severe pains in the left wrist, localized centrally and dorsally, normal range of motion. And you see the follow-up after 2 years, full range of motion, no pain, normal strength. In conclusion, the arthroscopic bone grafting for intraosseous lunate bone ganglion is a really reliable, safe procedure. The technique is simple, easiest, and more accurate, of course, than an open procedure. The long-term follow-up showed us very satisfactory results. Thank you very much.
Yes, Prashant. Thank you, Professor Metola, for the very interesting presentation. Yes, over to Prashant.
Yeah, there is a question. I think Professor is online. Question is regarding use of fibrin glue to seal off the repair.
I'm not sure if Professor Mathula is online. Okay. That PC Ho can perhaps.
Yeah.
Well, yeah, I think Crystal is not here, but I think the use of fibrin glue is just optional. Because probably it's unlike the scaphoid non-union series. I think you will need a very meticulous control of the graft inside the joint. But here, I think basically it's just like a fill up the space of the ganglion. So in fact, probably if you even don't put anything after the correcting the ganglion, it probably can also heal. So I think in this place, yeah, I don't think it's absolutely. I saw actually Jeff have a question about the volar. If the ganglion is in fact, it would be the same question for me if Crystal is here. I want to ask him because it seems like his approach is all the way from the radiocarpal joint, and all the case ganglion to show up is actually more like in the dorsal side, near the scapular junction. That it makes it possible using his approach from the dorsal approach from the radiocarpal joint. But in fact, actually, you all may know that my first case of arthroscopic bone graft is actually not in a scaphoid non-union, but it's actually in a lunate cyst. And in fact, it's located more volarly. That's why actually I go to the mid-carpal joint. And because in the mid-carpal joint, you can access the volar side very easily. And it's very flat there. So you can create a small hole, cortical window and at the lunate, and then you can reach the cyst, and you can do the curettage and bone graft accordingly. So I think probably I will use the mid-carpal approach for the volar side, but probably not in the radiocarpal joint. I don't know whether Jeff has any other experience or other way of thinking about this question.
And PC, I think even in the mid-carpal approach, the gravity assists your placement of the graft.
Yes, yeah, it's also more clear. Yeah, that's true.
More clear, exactly.
So PC, yes, you go through the articular surface when you're in the mid-carpal joint. You make a small hole in the lunate on the palmar side to get into it. Is that accurate?
Yes. It seems that you have to go through the joint, but I think anyway the hole is not big, so I don't think there's any sequelae on this aspect. Yeah. Anyway, when you actually make the approach to the lunate cyst, most of the time you have to go through the joint. But I know that in Beijing, maybe some friends in Beijing can allow. They actually go through at the near the dorsal capsular junction. So where actually there's very little articulation surface at this area. So probably that also makes sense, because if that is the dorsal capsular insertion around the lunate, it also a good access to that. Except I think the approach is a little bit difficult, because you really have to go to the very dorsal side of the lunate.
What I found helpful too is to put a cannulated drill in from dorsally and go into the ganglion and just go through the hole. That's another way of doing it.
Greg Bain here. The ones with the volar side, we've gone through the volar portal, that inside out technique using the Wissenger rod. That works well. And I think it's all about looking at your CT scan and working out exactly where the defect is. We've tended not to add the bone graft, as PC said, but there's plenty of people who are adding bone graft. And I think now with the gem sheety needles and also using the sheath of a IV cannula or a hypodermic needle, I think that's actually another technique that works well. So I think we're better at getting the bone graft in, but I think if you check it on the CT, you can go volar or dorsal to whatever's the best position to get the defect.
So how many of you would keep your bone graft ready before you scope in? Yes, PC.
No, I said I will put bone graft. You said, okay, maybe you should show on this.
You keep your bone graft ready before you put in your scope, because you know from your CT what is the requirement, or you do your scope, have a look, and then plan your bone grafting. And most of the time you take it from the distal radius, olecranon, the iliac crest.
The other point,
Yes,
probably
Jeff?
more important than the bone grafting, is the debridement. So we think it's a ganglion that's gone into the bone. There's probably a vascular foramen there. I'm not sure exactly what's there. Maybe one of the other fellows can tell us. But basically, it sort of protrudes into the joint. So I try and get rid of all of that, any of that granulation tissue if I can. And I think if you drill it out, and then I actually do the lunate first. That way, if for some reason I decide not to bone graft it, and when you put the scope in there, you see all this hemosiderin staining and the almost like corticalized of the inner wall of the cyst. So I think you should probably break that down so it tends to bleed a bit in the same way as you would do with any other bone grafting technique.
Yeah, I think with all ganglia, it's a pressure phenomenon. They nearly always have a thin white layer of fibrous tissue around it. And I agree with Greg, if you're going to take it out, you've got to get rid of that as well if you can. I think the really interesting ones are the very, very large interosseous ganglia, because I've seen several elderly people, too, in my life, that have presented with a disintegrated lunate, and there was no evidence of avascular necrosis. And you look through their x-rays, they had a very, very big cyst in their lunate, like it was an emotional cyst, like it was going to break. And I think they definitely need bone graft. And when they're like that, we'd be getting the fellow to harvest the bone graft at the same time, because it's, you're going to use it.
Thank you.
I saw Paranek asked about post-op protocol. I think we just go moving the wrist right away, because actually there's no risk of the bone graft inside. But once the wrist was put in normal position, the wrist there's a little space there, and the carpal bone itself will actually control the graft positioning. So early mobilization will be the goal.
Thank you all. Prashant?
Yeah, thank you everyone. So we'll move on to the next talk by Dr. Praveen Bharadwaj. It is on articular damage pattern in patients with Kienbock's disease. It is a series of 60 patients. Praveen, please.
Good afternoon. I'll be talking about our observational study of the pattern of articular cartilage damage observed in patients with Kienbock's disease. We all are familiar with the staging of Kienbock's described by Lichman from 1 to 4. However, clinically, one easily observes that most of the patient presents when they are in stage 3. Probably this is the stage where the micro fractures make result in pain and patients become symptomatic. In fact, 80% of our patients presented and they are in stage 3B or progressing towards arthritis. However, the progress towards arthritis, the pattern is not very clear in the literature, and it is very important to know that pattern of involvement, because when you are doing a proximal row carpectomy, you need to have a good articular surface of the lunate fossa and of the capitate. If the articular cartilage of the lunate articular surface is involved, then the patient does not seem to be a very good candidate for doing a proximal row carpectomy. However, the literature about this fact is quite sparse if it related to Kienbock's disease, except for the arthroscopic classification described by Dr. Bain. However, many of the people may not be doing an arthroscopy before doing proximal row carpectomy for Kienbock disease. Hence, the aim of our study was to provide the articular cartilage damage pattern involvement and to suggest the treatment algorithm to tackle any intraoperative challenges which one may encounter while doing such a case. From 2009 onwards, we started noting the articular cartilage involvement pattern in all these patients, and we found that out of 102 total cases, 78 were type 3B, and we planned proximal row carpectomy for all these patients. 41 of the patients had perfectly normal cartilage, so they were very suitable for doing a proximal row carpectomy to get a very good result. However, 37 patients, we noted that the articular cartilage of the lunate articular surface was not that perfect, and which amounts to 47%. So that means in half of the patient, you may find that the articular surface of the lunate articular surface is not good, where the future capitate is going to come after you do a proximal row carpectomy. However, many of these patients, the articular cartilage loss is very mild, a very spotty one or a very superficial one, and we can still go ahead and do a proximal row carpectomy. However, in 25% of the patient, that is 20 of 78 patients, we noted that there was a full thickness loss of the cartilage, precluding a conventional proximal row carpectomy. So in these patients, we changed the decision intraoperatively to either an interposition proximal row carpectomy by interposing the capsule in 9 cases, doing a scaphocapitate fusion in another 9, and doing a sling operation of FCR after excising lunate in 2 cases. All of these things were done during the same operation. The pattern of involvement, if we draft it out, it appears that 47% of the patient can have an articular cartilage involvement, with all having involvement of the lunate articular surface of the radius. 2 had an additional involvement of the capitate head, and only 1 patient had involvement of the scaphoid articular surface, and that too only the dorsal rim. The overall other cartilage was intact, only the dorsal rim had some arthritis osteophytes. So to summarize, the articular cartilage damage pattern was something like this. So we could further categorize type 3B as 0, where the cartilage is normal or it is a very superficial or a patchy loss. 1, where we have a full thickness loss of the cartilage at the lunate articular surface of radius. 1+, where additionally capitate head articular cartilage is lost. And 2, where there is involvement of the scaphoid articular surface. We can note that in 20 patients, the full thickness loss precluded the conventional proximal row carpectomy. So we can see that there is a big transition. All these patients belong to the category between 3B and 4, but none of them had a panarthritis. So articular cartilage damage could be seen in half of the patient. However, in 1/4, it may be so severe that you may not be able to do a proximal row carpectomy. So when doing a proximal row carpectomy for a patient with Kienbock disease, it is better to be prepared for interposition proximal row carpectomy and scaphocapitate fusion, depending on what cartilage involvement you observe during the operation. So we routinely take a long dorsal capsular flap, which will help us to interpose it in case we require if the articular surface is not nice. Before excising the scaphoid, we inspect the articular cartilage of the lunate fossa of the radius. If the lunate fossa is good, we go ahead with proximal row carpectomy. However, if the lunate fossa is not good and there is a full thickness loss, we still have the scaphoid and we can convert our procedure to a scaphocapitate fusion to get a good result. In case the patient is low demand and more than 35 years, we prefer to do an interposition proximal row carpectomy, interposing the dorsal capsule which we have kept ready. Either ways, you can get a pain-free mobile wrist in all these patients. To summarize, when we are doing a proximal row carpectomy in Kienbock's disease patient, we need to be well prepared that we can observe an articular cartilage loss in these patients. As a routine, take a long capsular flap. First, inspect the lunate fossa of the radius for any cartilage loss. If cartilage loss is not much, we can go ahead with proximal row carpectomy. However, if cartilage loss is full thickness, intraoperative decision change is very easily possible. You could do an interposition proximal row carpectomy or convert to a scaphocapitate fusion. And in either ways, you can get a pain-free and mobile wrist for the patients. Thank you.
Thank you, Praveen, for that excellent presentation. Can we have some questions?
Could I make a comment?
Sure. Thank you.
Yes, please.
Firstly, congratulations. A very nice presentation of a big series of Kienbock's with it well described as to the distribution of the articular changes. I think the changes were similar to what we've found before, although your series would be larger than sort of what I've put together, I think. But we have published some of ours. We've also published our long-term results. I would certainly encourage you and others to use arthroscopy to help define exactly what these changes are. I think that's a great way to do it. And then the idea of your algorithm-based approach to go to one treatment or the other, I think makes a lot of sense. Two things. One other comment. I think you probably should incorporate some of the way that you classify them. I think you should probably bring in the classification that we developed because it fits into what you've said. Our experience is the same. I don't think I've ever seen a case with scaphoid facet involvement. But I do have a question for you. The interposition arthroplasty with a proximal row carpectomy, I've seen that published. I've never done that procedure myself. I'd be very interested to know what you think of the outcome of that procedure from the clinical cases you've done.
Yeah, actually our outcome of the interposition proximal row carpectomy has been quite nice. And we have done total of 15 cases of interposition proximal row carpectomy with a maximum follow-up of 8 years. None of them have required a conversion to wrist fusion yet. But I must say that there are 2 patients who came telling that they have pain. But when they were told that the next option is wrist fusion, they have not come back after that. So I think it is good, but maybe not as good as regular proximal row carpectomy. Yeah, thank you.
There's a question from Parag Lad. Your interposition flap is proximally based or distally based, capsular flap?
Yeah, that is a nice question. And actually, if you are taking a proximally based flap, you need to prepare well in advance because then the flap has to be raised from the base of the metacarpals. So that requires a much bigger incision. So what we generally do whenever we are doing a Kienbock's disease proximal row carpectomy, we take a distally based flap, but cut the capsule at the very margin of the distal radius. So if you are cutting at very margin of the distal radius, that flap is enough to reach to the capitate on the volar side if you require to interpose, and still you don't take a bigger incision. So we take a distally based flap and cut the capsule right at the margin of the distal radius so that the length is adequate. In case you don't require it, you can just place it back.
Yeah. Yeah, Anirban has suggested whether to go for a wrist arthroscopy and staging.
Yeah, I know. Actually, Professor Bain is there, so that
That's
is a
what
very
Professor
nice thing
Greg
that
Bain
you
mentioned.
can. Yeah. So what he mentions is very much correct. So, but I think all of you also may agree in Indian setup, if we do arthroscopy at one place and then do the operation, it becomes two operation. Or if you are doing scopy and operation at same stage, even then, since all the decisions provide the same type of outcome, I think it is not required to do an arthroscopy additionally. That was the point which I wanted to convey.
Okay.
Praveen, we found proximal based flap is much easier to insert and it gives a little better range of motion compared to the distal based. What's your opinion on that? I mean, the two patients you spoke about having pain, could it be where the flap is not reaching the volar aspect very easily? Is that a reason?
Yes, sir. You're right, sir. So the proximally based flap, you can get a much better length and it reaches more easily. But I think this distally based flap, the length is enough sufficient to reach to the volar aspect of capitate. And incidentally, out of these two patients, we have each type flap. One is the proximally based and one is distally based. So I think the flap length didn't matter much. But these patients had more deeper involvement of cartilage, and maybe that subchondral cysts are the one which are causing the pain. But I do agree, if preoperatively itself you see a patient where our MRI itself has told or X-ray itself is showing a lot of subchondral sclerosis, and you are very much sure that you are going to have a bad lunate articular surface, it is good to take a proximally based flap. But
I think
otherwise,
that's when the
cases,
sorry. Yeah, please go ahead.
Yes,
sorry.
Yes, sir. So in case we preoperatively are quite sure that there is a full thickness loss, we be prepared and take a proximally based flap, which is much longer. But as was seen in our series, half of the patients had involvement of the lunate articular surface. So every patient, there is no need to take a very long proximally based flap. So when we are not sure that the articular cartilage is much, you take a distally based at the margin of the distal radius. And in case you require, we can interpose.
And I think that's the point. That's the time where your scopy would help, where you want to take this, change the flap design.
Yes, sir. So in case we have experience of scopy, I think it is very, very, very good, very fair to use it. But what other thing message which goes is, it is not must. We can take the decision intraoperatively also. That's what I mean to say.
Definitely agree on that. Thank you.
You also, when you change the decision to go in for a scaphocapitate arthrodesis, and then is the time you excise the lunate or you preserve the lunate?
Yes, sir. So if the lunate is fractured, and then we should excise it. But only important thing is to leave some volar cortex of it intact so that the scaphoid does not slip onto the empty space on the lunate side.
What does Greg have to say on this?
We're concerned about excising the scaphoid leading to ulnar translocation. And the model, in fact, David Lippman's about to give his talk coming up, but I think the concept is that if it's very comminuted and very necrotic, then you probably can take it out and it won't make much difference. Instinctively, I think if you do that as an arthroscopic procedure, you probably get less ulnar translocation, but I don't have any evidence to prove that, but that's instinctively. But I'd just like to acknowledge again that presentation. It was very nice work, and interesting to see the interposition arthroplasty as well, which is something we've not really done much of.
Dr. Bain, one question. If we are doing a lunate excision, is it worthwhile to fix the opposite column between the triquetrum and the capitate, in addition to the scaphocapitate fusion?
To fix what, sorry? To fix the
other column, the between the triquetrum and the capitate. Yeah.
No, I don't think you need to do that. If you're going to do a scaphocapitate fusion, that's not a small procedure, and that's enough. So if you start fusing on the ulnar side, I think you'll then get problems of ulnar carpal impaction. So that what's interesting is that triquetrum can move up and down. There's a lot of motion of that triquetrum. If you lock that in position, I think you'll get ulnar-sided wrist problems. So I think you're best to leave that to move where it wishes to and not impinge.
And yeah, that's again reinforced when you do it arthroscopically, your preservation and then the translation is also less. That's what Greg is trying to say. Yeah. Thank you, Greg, for your inputs. Thank you, Praveen, for the wonderful paper. So shall I call Amit to speak on long-term results of PRC, proximal carpectomy in Keen box?
Good afternoon, Dr. Bhatt and organizer, to giving me this opportunity to present results of long proximal carpectomy in Keen box disease. As we know, when Keen box disease is progressed into 3B stage, then salvage procedures are the options, and which includes proximal carpectomy, limited carpal fusions, total wrist fusion. Ultimately, the aim is to get the pain less range of movement and grip strength, and that is more important for the functioning of the patient through its normal activities. Although there are various studies which comparing the proximal carpectomy and limited wrist fusions, Nakamura study says that there is no significant, statistically significant difference are there. Even this comparative study published in Korean Medical Journal says that in advanced Keen box disease, proximal carpectomy seems a better option, better option than limited carpal fusions. So my experience also says that proximal carpectomy is better than limited carpal fusion. So I looked into these 23 patients operated between this period, and we found that 3 patients which were of type 2, where radial sorting osteotomy was done, and in type 3A, one patient was there where negative neutral anal variance was there, so core decompression was opted. In rest of the 19 patients which were of 3B stage, 13 were operated by proximal carpectomy, 1 by the primary total wrist arthrodesis, and in 3 patients, scaphocapitate fusion was chosen. And in 1 patient, radial shortening osteotomy, and even in one patient, STTK wiring was done to offload the lunate. These 2 cases were of very low age, 15 to 17 years of age. So, although we tried to follow all the PRC patients, 3 lost to follow up, and the 10 patients who were followed were of 17 to 45 years of age group. All were female. Mean follow-up was 5.8 years, and grip strength was 70% of in comparison to the opposite hand. Mean dorsiflexion was 62 degree. Palmar flexion was restricted to 24 degree. 3 patients had occasional pain while doing household work, but it was not the same pre-operative pain, and rest of them are having no pain, and nearly all patients return to their activity of daily livings. 1 patient was significantly complaining of radial sided wrist pain, and when I evaluated and full radial deviation and ulnar deviation X-ray was taken, then there may be possibility of some impingement of the capsule. So advised for radial stylotomy. That can be done primarily also, but she denied for this. What I inferred that she was not having so much significant pain, or she operated elsewhere. Another, this 40 years old right-handed female, she had presented with pain and swelling. You can see there is bogey swelling on the radial side of the wrist, and Keen box disease was quite advanced in 3P stage. So opted for proximal carpectomy, and you can see there is excellent range of movement at 5 years follow-up. You can see this transverse incision. Usually, I'm shifted to this transverse incision where proximal row carpectomy is done. So it is able to produce good cosmetic results. Another example of 35-year-old right-handed teacher. She was operated by proximal row carpectomy for an advanced 3B Kienbock disease and able to achieve excellent results. Good ulnar deviation was also achieved, but radial deviation was restricted. And in 9-year follow-up, she was able to achieve nearly normal range of movement, and this was a painless movement. So she was able to do all the activities which she was doing previously. This 36-year-old right-handed housewife presented with some advanced 3B Kienbock disease. She had limitation of range of movement preoperatively, and when we exposed, there was some erosions in the cartilage surface of capitate head. So capsular interposition was done, and at 4.5 months follow-up, there was limitation of some range, but pain was disappeared significantly, and she had restricted radial deviation, but good ulnar deviation was there. And when I serially follow her, surprisingly, after 4 or 5 years, she developed some sclerosis of the cartilage of the capitate head, and also the lunar fossa of the radius, but she was not having any arthritic pain. And then when I followed after 3 years, the sclerosis slightly increased, but pain was not there. So although she had restricted range of movement, but it was painless. And these females are really hard-working housewives. They are working in village, and she was able to manage all her activities of daily living. So in conclusion, proximal row carpectomy is effective alternative in advanced stage of Kienbock disease. It preserves reasonable range of movement and grip strength in the long run also. Capsular interposition sometimes may be required if there are early changes in the capitate head. Thank you for your kind attention.
Thank you, Dr. Vyas, for that presentation. Any question or comments from the panel?
Would you, Amit, would you make your decision based on the high demand or a low demand race? Would you change your decision to a partial fusion in a stage 3B?
Not really. Initially, I inclined towards the scaphocapitate fusion, but later on I found that even the high demand patients are able to perform the all activities. So in my practice, most of the are this proximal row carpectomy patients.
Another question from Parag Lad. Do you consider posterior intraosseous nerve neurectomy?
No, I don't consider.
If there is no much questions, then shall we go to the next topic? The next talk is on precision classification and treatment algorithm for Kienbock disease by William Penka and David Lichman.
Hi, my name is Bill Pienka. I'm a hand surgeon in Fort Worth, Texas, and I'm honored to be here to present the work that myself and my colleague, Dr. David Lichman, have done recently on Kienbock's disease. In 1977, Dr. Lichman introduced the initial classification system for Kienbock's disease based on radiographic findings, and this has been modified several times since then to now include a treatment algorithm. The problem with Kienbock's disease, however, is that there are too many treatment options because there's many etiologies that have been proposed to lead to the development of Kienbock's disease. Here you can see just some of the proposed etiologies for Kienbach's disease, ranging from traumatic causes to anatomic variations, vascular conditions, as well as different coagulopathies and other miscellaneous conditions. And we're finding out that medications, genetics, and the role of osteoclasts may not only be etiologic factors, but may exacerbate the root cause or act as a catalyst for the development of lunate osteonecrosis. In addition to the numerous etiologic factors that have been proposed for Kienbach's disease, there's also been a multitude of treatment options which have been proposed for different stages of the disease. The numerous factors that contribute to the development of Kienbach's disease, as well as the numerous treatment options, can be confusing to the surgeon that is tasked with addressing this condition. The initial Lichtman classification system seen here is based on radiographic parameters seen on X-ray and MRI. Greg Bain and his team in Australia introduced an articular-based classification system based on the condition of the cartilage seen during wrist arthroscopy or on MRI. They subsequently modified this to include a treatment algorithm based on bypassing what they considered non-functional or involved articular surfaces. Rainier Schmidt and his German radiology colleagues introduced a classification system based on contrast-enhanced MRI, looking at uptake within the lunate to determine whether there was intact lunate perfusion, partial or complete osteonecrosis. What's really nice about these three classification systems in particular is that they pretend prognosis for these patients. And as such, we're able to make treatment recommendations and create a treatment algorithm to help guide surgeon decision-making for the treatment of Kienbach's disease. Once we put these three classifications and their prognoses next to each other, you can see it makes sense to combine these classification systems to create a much more nuanced and precise treatment algorithm. And that's exactly what we did in 2016. What you see here is the combined treatment algorithm that we published in the Journal of Hand Surgery in 2016. The problem with this, as you can see from this chart, is that this is not a very nuanced and certainly not an easy to interpret chart. In order to simplify the combined treatment algorithm, we came up with the key questions of Kienbach's disease. And these questions are as follows. What is the age of the patient? Second, what is the state of the lunate, and is the lunate affected in isolation? Third, what is the state of the wrist? Does the disease extend outside of the lunate? And other things that need to be considered are what are the patient's goals and what do they want, as well as what can the surgeon offer. As we take each key question individually, we have to start with what is the patient's age. And this is important because we know that young patients do well with non-operative treatment. In patients less than 15, non-operative treatment should be the mainstay for Kienbach's disease. We also know that patients that are older than 70 years old tend to do well with non-operative treatment, and their symptoms tend to improve with time despite radiographic progression. For patients that are between 21 and 69 years old, however, we suggest moving on to key question B and key question C. The second key question that we must ask ourselves is what is the state of the lunate, or is the lunate affected in isolation? And if it is, the patients will fall into one of these three categories, where the lunate is intact, compromised, or not reconstructible. Treatment strategies and treatment recommendations can be found here. If the disease extends outside the lunate, we move on to key question C. What is the state of the wrist overall? And here we have three subcategories based on the involved articular surfaces. In class C1, there's carpal collapse, but the articular surface of the distal radius is still viable. Class C2, there's non-viable or involved distal radius cartilage in either the lunate or scaphoid facet, but not both. And in Class C3, there's advanced carpal arthritis, or what we call KDAC, Kienbach disease advanced collapse. The treatment recommendations seen here involve bypassing the involved articular surfaces. We recently published what we call the Unified Classification System of Kienbach's disease, addressing the three key questions in the Journal of Hand Surgery. This table is taken from that publication, and you can see we've made treatment recommendations based on where patients fall into the Unified Classification System and their answers to the key questions. To summarize, don't be overwhelmed by the numerous treatment options or the complicated treatment algorithm here. Do a complete workup on all these patients to include X-ray, MRI with contrast, and evaluation of the cartilage either through arthroscopy, MRI, or direct visualization intraoperatively. Remember the key questions. What's the patient's age? What's the state of the lunate and what's the state of the wrist? And don't memorize this treatment algorithm. Reference the article, save table 5, and reference it when you have these patients to help guide your decision making. We thank you for the opportunity to present our work and be happy to answer any questions at my email seen on the screen.
Thank you, Dr. William Paintka, for that, throwing some light on putting some treatment algorithm for Kienbock's disease. Bharat, can you summarize?
Thank you, William, for the excellent algorithm, in summarizing the treatment of Kienbock's. Greg, any comments?
Yes, so no, I totally agree with it. In fact, I'm one of the authors, but so I think it makes sense. And basically, the age comes down. We know that in the patients with Perthes disease of the hip, they do well. And the same with the infantile or adolescent Kienbock's, they do well. And so then you go on to, is the lunate intact, compromised, or not salvageable? And then the wrist, is it compromised or not salvageable? So I think it just falls into those things. So I think he presented it very well.
Thank you, Greg. Any other questions?
Actually, just one other comment. We've had, what I noticed years ago was that we would go to a meeting and someone would talk about their vascularized bone grafts or their proximal rows, and everyone sort of seemed to have their own preferred technique for Kienbock's. But the reason why I developed the arthroscopic classification was that I could see some patients had more advanced or less advanced, and that sort of come out in the presentations in this session. And this algorithm basically takes what we've done with arthroscopy and mixes it, so the arthroscopic plus the osseous and plus the vascular components. So I think it's a more comprehensive thing that brings everything together. So I think it makes sense.
Thank you, Greg. Thanks for the summary. Extremely thankful and honored to chair this last session of the APWA meeting. I thank my co-chair, Dr. Prashant. I thank all the speakers for the wonderful session. And it was a great meeting with all the stalwarts in the field, the risk enthusiasts on the same platform, discussing very interesting issues. Over to Dr. Abhijeet for the valedictory.
I think all good things must come to an end. And but you cannot end any August event like the SAPA meeting without extending a heartfelt gratitude. And my gratitude goes out to each and every one of the Wrist Society of India members, as well as our colleagues and friends back home. Special mention, Professor Anil Bhatt, Ravi Bharadwaj, Rohan Habbu from the scientific team, S. Prashant, and then also the organizing secretary who, unfortunately, because of some personal reasons, could not be here, Pankaj, Ahire. Also Professor Tahir, Ansari, my friend Amit Amit Vyas, and each and every one. The names are too many to kind of take. The fault is all mine if I miss out on any names. But you guys have been a pillar of support. We were gearing up for a fantastic meeting in person. And this was going to be a showcase event for wrist surgery in India with so many leaders in the field. But unfortunately, we could not do any better against the pandemic situation. However, I'm sure that the APWA leadership will consider giving us another chance to host a meeting in person, and we will be able to deliberate and discuss and learn more from all these stalwarts in person. I want to thank the APWA leadership for giving us the opportunity to host the 7th APWA meeting, albeit online. And love for the wrist, as worded by Professor Ho, brings so many people together from the east to the west, and of course, the central part of the world. We are bound by an unseen bond, which is the camaraderie that we enjoy amongst ourselves, as well as love for the subject of wrist surgery. I would like to thank the founding president, Professor Ho, the president of the APWA, Professor Wendong Shu, the secretary, my dear friend Ju Yup Lee, and the entire EC, as well as all the past presidents for their guidance. I would like to make special mention of the Congress and the Scientific Committee Chair, Dr. Bo Liu, who worked very patiently with us and helped us finalize the program. The program was very well appreciated. I think the topics were wonderful, and they were the brainchild of Anil Bhatt, as well as the education chair and the scientific committee chair. I will not take too much time here because we have well past past 1 year, 1 hour since the end of the Congress was supposed to be. We look forward to seeing each one of you and as many as possible in person in Singapore next year. I'm certain that Andrew will set up a fantastic platform for us to meet again, deliberate, learn, and enjoy friendships and celebrate friendships. Once again, I would like to thank the delegates who have been with us. I would like to thank Ortho TV for taking the efforts and giving us the time and the platform to telecast this meeting. I would like to just make a mention that these recordings will be available for later viewing as well. So once again, thank you very much. Sheshe, merci beaucoup, dankeschön, and we'll see you again. Thank you so much.
Thank you.
Thank you. Thank you, Abhijeet. Thank you so much.
Thank you. Of course, I shouldn't forget to mention Gloria, who has been at the back office managing last minute requests. Gloria, thank you very much. It really means a lot. Your support is priceless. Thank you. Have a great day, everyone.
Bye.
Bye. Take care. Thank you. Thank you, everyone. Thank you. Have a wonderful Sunday.
Thank you.
So much.
Thank you.
Bye-bye. Bye. We can stop the meeting, the live telecast, Ortho TV now.
Thank you.
Thank you. We would like to hear about some feedback. How can we improve our future meetings? So if someone could, the senior faculty especially, and some of the delegates, if you can give us some feedback, that would be great. PC, we would like to start with you. We can't hear you. You need to unmute yourself, please.
Congratulations. Can we have a picture together? I think we should have a picture together.
Yes.
Gloria can help us to press the button.
Sure. Can everyone please switch on their cameras?
Yes. Thank you so much for the great organization works.
Thank you so much. Thanks for being a part of this. This couldn't have been possible without you.
So, Gloria, you can guide us. 1, 2, 3. Someone press the button.
Is Gloria there?
Someone have to press the button.
Just a moment. I will wait a moment.
Okay.
I'll take the picture.
Okay.
Just a moment, please.
Good. All right.
Yes.
Okay, see you.
Okay.
Thank you.
Thank you.
See
you in Singapore again.
See you soon. Thank you so much.
Thank you.
Thank you. Bye.